reproductive technologies. What seemed to be a dream before now can become realities, with more than 8 million babies born with IVF since the first IVF baby born in 1978. In Merck, we share the same vision of being the partner of choice, providing innovative solutions, enhancing the couple's journey for parenthood. In today's meeting, our esteemed faculty members are going to share with us new advances in diagnosis, management, and ART laboratory procedures. Actually, I would like to thank the Emirates Society of Obstetrics and Gynecology for endorsing today's meeting and for their support for continuous medical education across the UAE. I would like also to extend the gratitude to ART or Art Fertility Clinics for providing the enriching scientific content of today's program. And now, without any delay, I just would like to invite Sheikha Dr. Ali Al-Qasmi, the Vice President of the Emirates Society of Obstetrics and Gynecology. Dr. Alia is a specialist of obstetrics and gynecology in aesthetic and functional gynecology in Mason Lutia and Al Garhoud Private Hospital. Dr. Al-Qasmi was named Inspirational Woman of the Year at the Arab Women Awards in 2016. I would like also to invite Dr. Carol Coughlin. Dr. Carol is the Medical Director of Art Fertility Clinics in Dubai. They will open and share together the first session of our meeting today. Thank you so much, and please, Dr. Alia, Dr. Carol.
Assalamu alaikum wa rahmatullahi wa barakatuh. I always prefer standing when I talk. I don't know why. Maybe it makes me feel lighter. Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, dear colleagues, it gives me great pleasure to be amongst you today in this event for advanced learning. I think Dr. Tamer gave a very good intro about infertility and the challenges that the couple are facing. I would like to add to that infertility is on the national agenda, and it's on a lot of the public level Emirates in regards to what we call projects and initiatives to increase reproduction in the UAE, which makes this event a very important one and aligned to the national agenda. Not to delay you further, Dr. Carol and myself will be moderating the first session today, and we are having our esteemed speakers. I would like to start by introducing Professor Houman Fatemi, who holds the position of Group Medical Director of Art Fertility Clinics in UAE, Oman, and India. In 2008, he was recognized as a subspecialist in reproductive medicine and surgery by the European Society of Human Reproduction and the European Board and College of Obstetrics and Gynecology. His PhD is on the endocrinology of the luteal phase in stimulated and substituted cycles. And with more than 175 publications, he has given also more than 200 international presentations and conferences around the globe. Please welcome with me Professor Houman Fatemi.
Thank you very much, Sheikh Alia, Dr. Al-Qasmi. It's a pleasure being here. I would also like to thank the Emirates Society of co-hosting this meeting, and of course, Merck of giving us the opportunity of presenting here today. Now, the first topic which I'm going to present you today is a topic which is affecting, I think, the whole region. It's not only affecting the UAE, but it's affecting the whole region. If you take a look, you look right or left from where you are sitting, you know, Emirates, Dubai, it's a very multicultural society. You will see that we look different. We have different ethnicity, we have different backgrounds, we look different, but maybe also the body is different. Maybe the receptors of the body is different. Maybe there is something like ethnicity and infertility. Maybe based on how we look, how we live, we have different etiologies, different causes of infertility. Now, if you look, there is a big population from India in the UAE. If you look at the aging pattern of Indian women, we know that they have been accelerated by 6 years. I'm going to repeat myself. Women in India, it's not that they look 6 years older, by the way, the eggs are aging faster. And we know the number of eggs is directly correlated with the quality of the eggs, because inside those eggs, you have the genetic information. And we also see a certain decline of fertility, specifically in this region. Now, if you take a look at this graph on the left side, the graph on the left side was published in 2012, United Nations. You know that this region used to have big families. In average, 6, 7, 8, 9, 10 children is considered to be completely normal. But if you take a look at the decline of the number of children being born, I think we all agree it's like you drop a stone. It's a significant drop of the number of children. Now, you might say, yeah, but look in the West, also in Western countries, people have less children. Yes, but there is a difference. If you see a drop of the number of children born in the West, this number is linked to the economical situation of the country. So if you have a country like Greece, Italy, Ireland, sorry, Dr. Carroll, for Ireland, but if you have a country with an economical problem, you see the number of children drops, and after 3, 4, 5 years, it recovers again. So basically, you go from 1.8 to 1.5, and then you go back to 1.8. So there is a kind of stagnation, but you do not see what we are looking here. Now, what you see on the right side here, the anticipation was 1.7. The reality 1.5 years ago is 1.39. This is one of the lowest in the world, 1.39. You might say, okay, but it will recover and it will go back up again. Now, I put these graphs just to compare. On one side, on the left side, what you see are the data from UAE. On the right side, I just took a typical Western country, Germany. You see, if you go over the last 40, 50 years, there are ups and downs, but you don't see this drop. So I think we agree, something seems to be cooking here. And the question is it because people do not want to have children, or is it that the prevalence of infertility is higher, and that's the reason why we see a significant decline of a number of children born? Dr. Laura Melado, who is present in the room, she published this beautiful paper, and she clearly demonstrated that women in the UAE, they seem to have a more accelerated decline of the number of eggs. It means when women are young, 20, 25, 30, still it's okay. But from the age of 33, 34, 35, we see a significant drop of the number of eggs. And this gap becomes bigger and bigger the older women become. It means at the age of 36, 37, 38, women here seem to age significantly faster. The ovaries are aging significantly faster. The question would be, why is that? And this is a very interesting slide, because this demonstrates almost half of all patients we see in our fertility clinics, almost half of patients we see in our fertility clinics are poor responders. It means 40% of all patients we see, independent of each age, 20, 25, 30, 35, 40 are poor responders. Of course, the question would be, why is that? Why do we see so many poor responders? Much more than we would see in Europe. Then we started looking step by step, what could be the cause of it. Now, first we thought, okay, what differences do we observe in this part of the world? The first thing we see is consanguinity. Consanguinity is marriage in a family. We know if you marry your cousins, there might be some risks of genetic abnormalities, but that doesn't create infertility. We know that 20% of the world population is living in consanguine unions. On the other side, if you take a look at the number of children, consanguine couples have even more children than non-consanguine couples. So if you marry your cousin, you don't have any infertility issues because you will have even bigger families for various reasons. One of them is because consanguine unions, they marry at a significantly younger age. But the question rises, what happens with the subsequent generation? What happens with the children of couples who are cousins? And this is what we have done. So we have looked into the children in daughters of parents who are first or second degree cousins. And we clearly saw a trend towards lower number of eggs at each age category. So if you put it in this graph, you will see normally when you are young, you have a lot of eggs. When you get older, you have less number of eggs. But what you see here at the age of 20, 25, you have the same number of eggs than someone who is 40. So it seems that we have an accelerated aging on the number of eggs. And the same finding was reconfirmed in a very, very recent publication, again by Dr. Melado, who is present in the room, where we demonstrated in a big sample size that if you marry your cousin, your daughters are at risk of having an accelerated aging of the eggs. It means the number of eggs become older faster. And that will have, of course, an impact on subsequent generations. Now, the next point, because this is not the only reason that we see a drop in the number of children born, because that marriage in a family has been there for hundreds of years, if not millennia. So this is nothing novel. There must be something else contributing to that. Now, if you take a look at cesarean, if you look in Europe, the prevalence of cesarean is around 10-15%. WHO gave guidelines, you should stay below 15% of cesarean, but I think we all agree that the prevalence of cesarean in these countries, in the GCC countries, is much higher than the 10-15% which is recommended. What are the exact data? We don't know, but around 40 to 50%, at least 40 to 50%. Now what happens, this is a paper we published a few years ago in reproduction, you create always a small damage in the uterine cavity, and that damage will have an impact on the subsequent fertility. So there have been many studies looking into subsequent fertility of women who had a cesarean section. So with each cesarean that the patient is undergoing, the chance of a subsequent pregnancy reduces significantly. Now, this study was looking into IVF, but there are many other studies looking also in natural conception. Also, natural conception seems to be reduced. So one is marriage in a family, the children. Second one, the high prevalence of cesarean. The third one is obesity. Now, we know that the prevalence of obesity here is extremely high. And we also know, these are most recent data, it's around 40-50% really obese, and overweight is up to 60-65%. So 60 to 65% of women are overweight. What will happen if you're overweight? Obviously, the quality of the oocytes declines, the receptivity of the uterus declines, you have more aneuploidy, and you have less healthy pregnancies. And of course, even if you have a genetically normal embryo, you put it back in a patient who is obese, the chance of having a live birth declines significantly. So it's not only that you have an impact on the oocyte quality, even if the embryo is normal, the miscarriage rate is higher. So obesity is the third factor which is leading to this. Now, you might say, okay, consanguinity, cesarean, obesity, yes, but does that really contribute to such a significant drop? The answer is no. And I think this is the most important point that we have to focus on. If you ask yourself, what happened? What is the difference between lifestyle 50 years ago, 70 years ago. And today, I think we would all agree that there is a difference in lifestyle. We have now cars with air conditioning, we have buildings with air conditioning, all the cars have black windows. We try to avoid sun exposure. But please tell me, if you have a plant, you put the plant in a dark room, you give as much water and fertilizer as you want, but there is no sun exposure. Will that plant survive? No. The same is with us human beings. Sun is extremely important for various factors. And it's not only for the bone. And you know, it would be too simplistic to say, take a pill and you compensate your lack of vitamin D. Because the moment sun is exposed on the skin, you have a cascade of reactions which is initiated. And this cascade of reactions initiating from cholesterol, each one of these steps in between has a certain function. The end product is called 1,25-dihydroxyvitamin D. This is the end product. So when we give the vitamin D pill, we are giving almost the end product, but none of these precursors. Do they have a certain function? Maybe. And if you would give the vitamin D, you would mask a problem, but not stop the problem. Now, we know that vitamin D receptors are present and expressed in most reproductive organs, including endometrium, cervix, and also breast. And if you knock out in animal models the vitamin D receptors, there are no offsprings. There are no offsprings in knock out the vitamin D receptors. And interestingly, if you take a look at the map of the US, let's say you have the US here. This part of the US, let's say New York, Washington, it's mostly rainy. And on the West Coast, San Diego, Los Angeles, California, you have a lot of sun. So if you take a look at the data from the US, the same chain of IVF clinics, in the West Coast, where there is more sun exposure, they do significantly better than on the other side. It's not that they have better doctors or better labs. Could it be that the sun exposure plays a role there? And of course, we know that vitamin D has an impact on ovarian reserve. We know there are many, many data looking into the vitamin D levels. And if you have a white skin, you need to expose 20 minutes. If you have a very dark skin, you need to expose up to 2 hours sun exposure. And the sun exposure is UVB light. UVB light is present around 9 o'clock, 10 o'clock in the morning. So you need to have, based on a skin color, a certain time of exposure in order to maintain a certain level. Now, what is the prevalence of vitamin D deficiency among women in this region? 100%. 100%. So what will happen? If you look at the ovarian reserve, there is a direct link with the vitamin D levels. And interestingly enough, you know, we always try to reinvent the wheel. But this is an old study. I think it's from 1992, as you see here. If you ever have traveled to the Scandinavian countries, if you go to Finland, in January, it's 24/7 dark, no sun exposure. No sun exposure, dark. 12 o'clock at noon, dark. 2 p.m., dark. 10 a.m., dark. Look what's happening. Women don't get pregnant because there is no sun exposure. And once the sun exposure is there in the summer month, there is a higher activity of the eggs. And of course, if you take a look at the intrafollicular vitamin D levels looking to the outcome, there have been many studies looking into that. This is a study from Nikos Polizos when he was in Brussels working with us. Direct correlation between vitamin D and outcome. Another study, Pafoni from Italy, GCM, direct correlation. And this is why, even in the West, people started realizing there seemed to be a problem. We see that women from this part of the world seem to have an accelerated aging of the number of eggs. They seem to have more poor responders. But of course, the question would be, why do we see so many poor responders? So this is a study which was conducted a few years ago looking on the pattern women cover. If you have a burqa, it means you have a full coverage. You just cover your hair. Or based on your skin color and the pattern of coverage, you look how much vitamin D you have and what is your ovarian reserve. And what came out, there is a direct correlation between the skin color and pattern of coverage and ovarian reserve. Again, this is a recent study we published recently and we saw that, for example, women who cover their face and who don't cover their face, if you stratify based on the age, the less sun exposure there is, the faster is the decline of the number of eggs. So if you have a decline at a young age, let's say you are 32, 33, or 29, and you have a more accelerated decline, what will happen, independent of your age, you create more chromosomally abnormal embryos. This is important. It means if you are 40 years of age and you have a lot of eggs, or you are 25 years of age and you have few eggs, at the age of 25, you create more genetically abnormal eggs than at the age of 40. This is a very strong message, and there have been many studies looking into that. So age is not the only predictor of aneuploidy. The ovarian reserve is at least as big a predictor for euploidy. And this is a point we have neglected in the past. Another study that we have published a few years ago, where we looked into the intrafollicular levels of vitamin D, and we could demonstrate a direct link between intrafollicular vitamin D levels and the ploidy status of that embryo. A paper we published in Fertility, Sterility 6-7 years ago, where we described that the social cultural influences in the GCC regions should not be neglected. Another paper we published 3 years ago with Dr. Barbara in JARC, that we need really to understand the etiology of infertility in different parts of the world. So I think we can conclude it's not that one size fits all. There is something which is called, and we need to respect that, geography and infertility. We need to understand that parental consanguinity, if the parents of wife are cousins, there is a risk of an accelerated aging of the ovaries. We know that vitamin D deficiency plays a significant role in the aging of the ovaries. And also obesity, which is very prevalent in this part of the world, plays a significant role. And last but not least, I think before we conduct a cesarean, we need to be cautious. We need also to understand that a cesarean might have an impact on subsequent pregnancy. Thank you very much for your attention.
Thank you, Professor. We'd like to open if anybody has any questions. We have a 5 minutes time. Yes. Do we have a mic, please, for the audience?
Yes, that's also possible.
It's just sometimes the people at the back may not hear you.
Yes.
If you'd kindly just wait. The mic is on its way to you. Thank you.
Yeah, thank you. Is it working? Yeah. I think in the 50s, 60s here in this country, they were also completely covered and lacked the sun activity as well. What do you think?
They didn't have any Nissan Patrols with black windows.
Ah, okay.
They were living differently. There was no air conditioning. Women were more outside. And this pattern of coverage that you see today, it didn't exist at that time. It was a metal thing that women had, and they were working outside. They were more exposed. You had less obesity. They were working differently. And because there was no air conditioning, people were more active and more outside than inside. I think over the past 50 years, the lifestyle went upside down. It changed completely. And I think that is extremely harmful for the fertility. As you can see, there is really a significant drop in the fertility, and we see that. But unfortunately, there was not a correct data collection of that. You see, every country, you have a rapportation system. In German, you have this, you should know, Dr. Michaela being from Germany, you have das Deutsche IVF-Register, where you have registration of everything. Belgium, we have the BELRAP. In France, they have the French system. Here, there is no rapportation system. You see, there are patients undergoing treatment in different Emirates. There are patients, they go abroad, so that information is completely lost. So there is no correct collection of data. And I think it's time also to collect this data to understand what's the real prevalence of infertility in each of the GCC countries. Also to understand the etiology. You see, the papers we have published, they have looked into the most important thing, which is the number of eggs. And we see a significant drop. You see, in Europe, in Germany or Belgium, we don't see 40%, 50% poor responders at any age category. And I think this is something that every IVF doctor would confirm. We are dealing with a lot of poor responders here, and we need to address the etiology of it.
Thank you.
Hello, I like so much what you said, but just one comment. Those who are going to these fertility clinics are always rich and they can afford the prices to go there. But poor responders, because they are already maybe the obesity life, sedentary life, and maybe older like that. So we cannot collect data from this IVF in these countries. But like Europe and UK, they go to do it free in some areas. So they can be good responders, bad responders. Yes, you can collect data from these centers. But here, they must afford this big amount of money.
Yeah. I mean, in Dubai, it's correct, but in Abu Dhabi, no, because Abu Dhabi, Al Ain, and Western region, it's covered by the government. So independent which social class.
Just few clinics are covered, yeah.
No. I mean,
here in Dubai also.
In Dubai, yes, but in Abu Dhabi, no. So the data you have seen, there is no bias because this is affecting everyone. So there is no bias who can afford, who cannot afford, because if you live in Emirates of Abu Dhabi, it's fully covered. So this is why these data are not biased.
They
it's
do
really,
IVF free there?
Yes.
Okay, thank you.
You have another question?
Thank you, Dr. Fatemi, for this lecture, really informative. But any study done regarding the more cases that we are seeing now, gastric sleeve and rapid loss of weight, number one, the more endometriosis and many surgeries for the ovary, this is number two that we are seeing in our gynae clinic actually with poor ovarian reserve or low responder.
Yeah.
So do you have such a study about this one here?
So we didn't do any study on gastric sleeve, but it's correct that there are many women who are obese, morbid obese, they undergo gastric sleeve. But also the gastric sleeve is done on different patterns. There are many ways to do that surgery. So in order to do a correct study, you need to unify which operation was done, how many years ago was it done, what was the situation before that. So you have too many heterogeneity in order to study it correctly. Now, endometriosis, one of the papers that I showed you was about the cesarean. So endometriosis, one is genetically that they have it, and obviously these women, they already have low ovarian reserve, poor egg quality, but there is a different entity of endometriosis that we see more and more often, and this is endometriosis after a cesarean. And if you do a cesarean based on the place of incision and based on how you close the cesarean, there might be penetration of some endometrial cells and creating not only endometriosis, because endometriosis itself for us is not a major issue. What is a major issue is adenomyosis. And we see a lot of adenomyosis with patients who have had a cesarean in the past. And it could be, and this is in 70-75% of the cases, underdiagnosed. You see, if you look for adenomyosis, typically you would say the patients have pain when they have the period, they lose a lot of blood, but you have different pattern of adenomyosis. You could also have a full asymptomatic adenomyosis. But if you do the scan, you might see some calcification in myometrium. You might see some vacuoles in the myometrium. You might see in the myometrial endometrial transition zone some irregularities. You might see an asymmetric myometrium, which would be also indicative for adenomyosis. So I agree with you, endometriosis is an issue, but for us IVF specialists, adenomyosis poses a much bigger problem in combination with poor response. But I think it would be a good idea, because the prevalence of gastric sleeve is so high, to do a study on that topic. But as I mentioned, you have so many heterogeneity because you need to collect data before and after surgery and to see what was the difference between before and after.
Sorry, Dr. Fatemi, but if we take a study comparing C-section ladies who have multiple cesarean, who are frequently, we are telling them not to conceive unless 2-3 years, they are coming pregnant even before 1 year. And the same C-section with poor responder or less, let us say, infertility. I don't know if this is per se the ismocele is the cause of infertility and how frequent, because nowadays we are diagnosing nowadays the ismocele because we have more high resolution scan, TVS scan, the same surgeons, the same way we are doing cesarean now, how many years? And even with that small ismocele, the lady is coming back pregnant. So now they are more concentrating on the ismocele to correct before doing this one. Not every ismocele is significant, really. The study, to be fair, should compare C-section ladies who have multiple cesarean conceiving and ladies who have 1 or 2 C-section coming back with secondary infertility or let us say primary infertility. I think this is the thing.
What would be the bias of that study?
Well, I don't know, but nowadays...
Very simple.
The cesarean is there for many...
No, you're wrong about that. So we have a paper, Dr. Ashna is working on it currently. So if you do a cesarean, do you know what is the cause of an ismocele? What's the etiology of an ismocele?
We attend a conference from Latifa Hospital. They studied the ismocele by histopathology. They found like adenomyosis, as you said.
No. Etiology, cause, not adenomyosis. What is the etiology? What's the cause of ismocele?
The ismocele most probably adhesions in the C-section scar with the invasion of the endometriosis inside. This is the thing.
There are 2 reasons. Yeah. Why? There are 2 reasons for an ismocele. 2 very simple reasons. What's the reason of ismocele?
You tell me.
So first of all, you need to close in double layer. This is number 1. If you close in single layer, you will have a high, it has been published, I can give you a full presentation about that. The second one, if you lock your seizure. If you close and you lock, you have a high risk of having an ismocele. So basically there are 2 reasons of developing an ismocele. Number 1 is if you close in 1 or double layer. Number 2, if you lock or unlock. So this is the etiology of ismocele. If you say compare with or without ismocele, the heterogeneity would be, how was the cesarean done? Who did the cesarean? Was it closed in 1 or double layers? Was it locked or was it unlocked? You see, you already have heterogeneity. This is why many mistakes happen in our field, because studies have too much heterogeneity. You need to unify your variables. You need to have only 1 variable in order to draw conclusions. If you have 2 variables and you have a certain outcome, the question is it because of this variable or this variable? And if you take a look at pregnancies, so Dr. Ashnaw's paper that we are currently publishing, we looked in pregnancy after cesarean, and if you have ismocele, you can have ismocele, you can get pregnant, that's not an issue. The question is how much liquid is present in the uterine cavity. If you have no liquid, the receptivity is not impaired. But if you have liquid in the cavity, you have a significant reduction of implantation because your window of implantation is dismantled. It's not there anymore. So that's the etiology that some patients do not get pregnant. But if you compare cesarean with cesarean, I think that would not be correct because you have too much heterogeneity there.
Thank you very much, Professor Fatimi.
Thank you.
I think in the interest of time, we'll have to move ahead, but I'm sure Professor Fatimi would be very happy to take questions during the coffee break. So, our next speaker is Professor Boris Atta, who graduated from Istanbul School of Medicine in 1998. Following residency training in obstetrics and gynecology between 1999 and 2003, he completed subspecialty training in reproductive endocrinology and infertility at the McGill University, Montreal in Canada. He has over 130 publications on female infertility, endometriosis, and clinical aspects of assisted reproduction to his credit in very reputable journals. Prior to joining AORT Fertility Clinics, he was an associate dean and the chairperson of the Department of Obstetrics and Gynecology at Koç University School of Medicine in Istanbul. Professor Atta today will be discussing how to make the most out of ultrasound in infertility practice. Professor Atta, the floor is yours.
Thank you.
Dear chairpersons, dear colleagues, it's a pleasure to be together. Thanks to Merck for organizing this activity. And yeah, probably I've given really over 100 lectures or speeches. I mean, since this is not even my first speech in Dubai, I came for other meetings, but as the first time with UAE Obstetrics and Gynecology Society, I really feel a bit excited, and it's difficult to talk after such a vivid talk, but I'll try to do my best. So the title is a bit, let's say, larger than what the content is, so I'll just focus the presentation on assessment of myometrial anatomy today. And if you have other meetings, I'd be more than happy to go into other details. So these are my disclosures. None of them are relevant. And today, as I said, I'll be just focusing on myometrial anatomy. Well, let's see. Sorry, how does this go back? Okay. All right, let's see. It's going a bit slow. All right, keep going, please. I mean, in the original, there was the Eschre-Ezge classification of uterine anatomy, normal, dysmorphic, septate, bicorporate, and unicorn. I don't know where they are now, but anyways, let's see. Here are the videos we checked. They were, showing properly, but now it doesn't on the screen. How does it appear on the computer there? No.
We have technical support, please.
Let me check. You just checked this before the presentation, but anyways, let's see again. My apologies. Yeah, not the best, so. Hello. Actually, we checked, it was okay. Right, that means I just need to walk to the other side. Okay. Better late than never, right? Okay. So, yep. So this is the most recent classification. Some of these congenital anomalies have implications for reproductive potential, some do not. And I'd say, most of them are easily recognizable by regular 2D ultrasound examination. But I'm sure we all come across patients who have, missed a diagnosis for several years, or have been going around with a different diagnosis than what they originally had. So I'll just try to show a few simple cases and try to keep it interactive. How we can assess uterine anatomy in a systematic manner. So there is, let's see. Maybe it's because, say, can we move to the next slide? This doesn't seem to move. Say next slide. Just say next slide. Say Sami. Okay. So it gives me the opportunity to calm down. Okay. So this is the first category, normal uterus, normal myometrial outline, normal endometrial cavity. And we don't always need an MRI or 3D vaginal ultrasound to understand how uterine anatomy is. even in the frontal section. Oh, so this is we need to go back. This is not, all right, fine. It looks like working now. So that's normal. And depending on your choice, we need to scan the womb in two different sections. One is the sagittal, the other is the axial. I mean, I start with sagittal most of the time. I mean, I try to repeat the same thing in every exam, so I don't miss or I don't forget or I don't, nothing escapes my attention. What I do is, sweep the uterus just as a 3D scan does automatically from one side to the other after I align the probe in the same axis with its proper sagittal plane. So what I'm trying to show in these images is, you see the color codes? I mean, each line corresponds to the image with the same color frame. On one side, in the normal anatomy here, we would see, a small endometrium right here and a long myometrium all the way. As we move towards the center, endometrial line will get longer and the myometrium will get shorter. And in the midline, we should be able to, it's the proper axis, see the whole endometrial line with the cervix in its entirety. And as we keep going to the other side, again, the myometrium now will get longer, endometrium will get shorter, and on the corner of the triangle, endometrium will get even shorter and then disappear. And we should be seeing this consistently. And in the axial plane, same, you can do it from cervix to the fundus. I mean, that's how I do. Or you can do it the other way around. But what you see in a normal anatomy is at the bottom, close to the cervix, it's a narrow muscle and a tiny endometrial line. As you move up, as the triangle will get larger, the endometrial line will get longer and longer, and at the top, it will disappear. There's a small, the top of the dome, small myometrial appearance, and it will just disappear. So what we do is basic. Now I'll show you a real-time video, if that works. Next slide, please, if you can. No, you want one back, please. So this is 2 slides away. Just go back, please. Okay, can you play? You need to press on the yellow arrow on the side. Yeah, almost. These were all running fine. Yeah, okay. See, this is sweep as I've shown in the image, from one side to the other. Exactly follows the same pattern. And now I'll try to move to the next slide myself. And it's supposed to start. That's the axial. As you see, the lining gets longer and longer, then disappears. That's the real-time image. Now I'll show different examples, and after each video, we can take a guess and then see whatever it is. I mean, is it normal, abnormal, or in any way? So this is the 3D image. Now this is another category. Let's play the video. This is the sagittal section from one corneal region to the other. Just disregard the fibroid. Looks slightly different. And I'll show the same uterus in the axial section. So any guesses how it looks like? Yeah, that gives the impression because of the final frame. Well, let me show you the axial again. Can I go back 2 slides? Yeah, here it is. Okay, so it just moved forward. It was a T-shaped uterus. The reason is basically if it was responsive enough. Yep. Let's see. Why does it work sometimes? Now, see the video. Oh, God. Okay. You see the endometrial line goes thin for a long time, then just extends shortly, and then finishes. In the sagittal section, what was happening is, if we could ever play the video, okay, you see the endometrial line does not gradually elongate, it just goes thin, and then in the midline you see the long section to the cervix, and then disappears again shortly. So, I mean, with 3D, it's easy to see, but I mean, you don't really need to see the 3D. Okay? So that's how it is. As the sections go from one side to the other, short endometrial line, long myometrium again. In the middle, you see the whole cervix, and then the endometrium does not get gradually shorter. It just gets short and goes like that to the other end. And when you scan in the axial section, it just keeps going almost in the same caliber without gradually enlarging. And then at the top, it just enlarges and then finishes. I mean, that small indentation feeling that you saw, you picked, happens in most uteri somehow. But real, as you correctly said, it could have been arcuate, but in real septum, it really takes a long way. Okay, so this is another one we've just seen. I don't know why. So just one more click. So there's another one from one side to the other, the endometrial line, midline. That's how it looks. And now we'll see the same from the other section, just one click. So that's, and that is septate, because what happens is it started separating earlier with myometrium, and it takes you a while to go to the other side. And in the sagittal section, what happens is you will notice a longer distance between the fundal serosa and the top of the endometrial line as compared with the corneal regions. So, in a systematic manner, if you do it slowly from one side to the other, with paying attention to these, it's almost always possible to have the correct diagnosis. Here, this is, sometimes people actually, especially in radiology reports, it's mentioned as didelphys and septate is sometimes confused with each other, but I mean, the difference is, as I'll show in the next slide, I mean, in one of the next slides, is the myometrial tissue filling in between, and in real didelphys, endometrium is really much further apart. So let's wait. One click. Does it lose connection sometimes? Okay. So it just went several slides now. Just slow. Okay. So there was a septate. Slow. One play. That's how didelphys looks. I mean, it's really difficult to confuse with complete septum. It's almost always all the way apart, and it hardly fits the screen. And if you're sweeping it sagittally, sometimes it may really confuse with a unicorn if the other side is missed. I mean, if you stop sweeping when one side is finished. In my experience, this is the one that is missed the most often. And I've seen women who have undergone even C-sections without the diagnosis when the uterus is enlarged. See if it's easy to pick it up. Just waiting if it moves. It shouldn't be that difficult to press a button, but anyways. See, the lining goes, and then it just disappears. I mean, you see the endometrial lining gradually getting shorter, and then it just disappears. So in the axial plane, so the endometrial lining does not get wider in comparison with myometrium, and it tends to deviate to a side, And so that is the unicorns. Okay. And again, I think we missed one slide, but anyways. All right. And then sagittal section, yep. So one side is almost completely normal. It gradually elongates. It looks normal in the midline. Then, rather than elongating on the other side, it just finishes. So it is the important next step, if we suspect a unicorn uterus, is to look for the other side. Okay? So sometimes there's a communicating or non-communicating remnant on the other side, and if we don't look for it, it's easy to miss that one. You see it's here on the other side. If it moves, please go ahead, right? It's on. Seriously. Yeah. Anyways, yeah. Skip anyway. So I think I made the point anyways. We don't need to see that video. On the other side, if you look for it, sometimes you'll find it. That's the same patient having a C-section. So we've gone through all of these. And despite all the video problems, I think we covered that in 15 minutes. So that's the whole point. I mean, it's a systematic assessment in two planes with, paying attention to the relationship between endometrium and myometrium. It is almost always possible to diagnose all these uterine anomalies with simple 2D vaginal ultrasound. A 3D helps if you have doubt, and actually it helps you convince other people looking at the scan. I mean, you can print it and give it to the patient, or another colleague can see the image. Because I mean, to have the same impression with 2D, you really need to see it in motion. Frozen images, still images are not that useful. All right, so thank you. That's all I would like to say so far. And in another, if you need some other time, I'd be happy to go through adenomyosis, endometriosis, bowel involvement, etc.
Just at the beginning. So we'd like to open up now for any questions from the floor. Professor Fatimi.
Yeah, what's wrong with the video? That's the question.
Could we have a microphone, please, for Professor Fatimi?
I mean, maybe they can turn your mic on, just on you.
Thank you very much, Professor Baris. Despite the technical issues, I think it was a very interesting presentation. One of the major issues we are facing currently in human reproduction, as discussed previously, is adenomyosis. Can you please give us some information on what we have to look for and what might be the possible impact of adenomyosis on implantation, findings on scan, and reasons why patients would have difficulties to conceive?
Very relevant question. To avoid time, I had deleted adenomyosis slides, but I think I can describe verbally. What adenomyosis is, etiology is unclear, but say either metaplasia or growth of endometrium into myometrium, right? So there are several ultrasound findings that may be associated with adenomyosis, but most of them are non-specific. So on the sagittal plane or any plane, wall asymmetry is an easy to pick sign. The wall, the side with adenomyosis, would look much thicker than the healthy side. So that's one sign. The other sign would be if you have hypoechogenic, like lacunar images, that could be those endometrial glands in myometrial tissue. That would be one sign. Or they can also present as hyperechogenic buds. That's also another one. And one sign which you can assess with 3D, MRI, or even with grayscale 2D is the assessment of junctional zone, which requires some practice. The junctional zone is the interface between endometrium and myometrium. It always looks like a hypoechogenic frame surrounding endometrium. In adenomyosis, its integrity is is breached, and it may look interrupted or enlarged in some images. I have some nice images of those. And as maybe except for junctional zone disruptions, since these are non-specific, if you see just one or two signs, they may not be necessarily established adenomyosis. I mean, if you see one wall like 5 times thicker than the other, even that would be enough, but the other signs would be there anyways. So the guideline recommendations are to see at least 4 signs that is strongly suggestive of adenomyosis. Okay? But so most patients don't have all that time. So if if your clinical impression is consistent with what you see, we can manage the patient as if she has adenomyosis. Adenomyosis is an inflammatory situation, in essence, okay? And those endometrial glands that are not supposed to be in myometrium probably undergo similar changes, creates inflammation, and some of them have openings into the cavity with drainage. So there may be debris, even invisible or imperceivable debris accumulating in the cavity. So there are two things to pay attention about reproduction, especially in the IVF setting. One is, even though not that strongly evidence-based, these patients may benefit from hormonal suppression of the disease before embryo transfer, so probably less inflammation. That's one. Secondly, I got this idea from you actually, as even though it may be imperceivable, maybe before the transfer cycle, flushing the endometrial cavity to get away that debris away from the cavity may be helpful. That would be nice to try that in a trial. But it is difficult to treat. Actually, it is untreatable. It's uncurable. We can suppress it. We can decrease inflammation. And hope she gets pregnant. Then management of pain or bleeding is another story.
Thank you. Thank you very much, Professor Boris. If there are no other
Apologies for the
questions,
videos.
so I'm sure Professor Boris will be happy to take any questions also during the coffee break. So now we'll introduce our next speaker.
Thank you. I'd like to introduce to you our next speaker, Dr. Laura Milado. Dr. Milado is a specialist in obstetrics and gynecology and reproductive endocrinology, IVF for Health Authority Abu Dhabi and Dubai Health Authority. She completed her PhD on ovarian reserve in 2015 with cum laude at the University of Autonoma in Madrid. I hope I pronounced that right. Dr. Laura Milado joined ART Fertility Clinics in 2016, and she is nowadays medical director at ART Abu Dhabi. Dr. Laura Milado is an author of more than 30 internationally peer-reviewed articles and book chapters, and today she'll be talking to us about, presenting to us pitfalls of ovarian reserve assessment. Dr. Laura, welcome to the stage.
Thank you. Thank you for the presentation. Thank you for having me here today. We are going to talk about pitfalls, and I don't know if you know this hero. He is Achilles. He is the best warrior ever in the Greek mythology. And his mother, her name was Thetis. She was a goddess. She was a sea nymph. And Thetis married a king, but a mortal king. And then the issue was that Achilles, the baby, was mortal too. And she was so worried that she wants to give to him immortality. And then what she did, she went to the river Styx. That is the river that separates the underworld from the world of the living. And she dipped the baby, holding him from the heel. So the only point that he was weak was the heel. And although he was the best warrior of the Greek mythology, he had one point of weakness. And this is what I'm going to talk today. I'm going to discuss some weaknesses that we can see in ovarian reserve markers, but it doesn't mean that they are not the greatest warriors that we have to evaluate ovarian reserve. So let's go to the point. And we want to evaluate ovarian reserve because it's one of the best, is one of the parts of the fertility assessments. When the couples comes to the consultation, we need to evaluate what's the matter with them. And we have 3 very important factors that we need to evaluate: the age of the woman, the ovarian reserve, and the sperm quality. So it's very important that we will be able to evaluate ovarian reserve. And why? Because it's very important to prevent unnecessary treatments. It's very important to give a proper advice to the patient. And we need to give to them this reliable counseling. What happens that we have very, very different levels of ovarian reserve, very large variations at any given age, and we have to evaluate it correctly. So we have 4 different predictors for the ovarian reserve. One is the age, the other one are serum markers, hormones that we can measure in the blood, dynamic tests like the clomiphene citrate challenge test, and we can do a scan to evaluate ovarian reserve. However, these different predictors for the ovarian reserve, they have limited predictive value, and what we have to do is to try to get the ones that are more accurate. And lately, we all know that severe data that has been published supports that antral follicle count and anti-Mullerian hormone are the preferred methods for predicting ovarian reserve. Let's go one by one. We'll start with the age. I'm sure that you can recall. I can see in this picture what we do every day in our consultation. That is the doctor telling to the patient that the age is extremely important for their fertility. And the most of the times the patients, they think, oh, everyone is telling me that and I want to get pregnant, I don't mind. But it's very important, they have to understand that age is the first determining factor for live birth rate. However, at any given age, we have different levels of ovarian reserve, and both factors, age and ovarian reserve, will be predictive for these possibilities for them to take a baby home. So there is a very nice publication by Richard Fleming. It's a nice review where he evaluates the 2 markers for ovarian reserve, the most important ones, antral follicle count and AMH. He discussed the advantages and disadvantages for both of them. So we are going to see one by one. Antral follicle count. Why is good? It has a good predictive value for the number of oocytes that we are going to retrieve when we do an IVF treatment, for the stimulation response. It's easy to perform. It's a scan that we can do in the consultation the first time that the patient comes. It's fairly non-invasive, as well as anti-Mullerian hormone. I think that a blood test is fairly non-invasive. But the main advantage that I can see for the antral follicle count is that gives to us immediate results. We do the scan, we see, we count, and we have a diagnosis. And we can provide this to the patient an immediate counseling of what do they have to do, what will be the next step. So this is one of the big advantages for the antral follicle count. This is an example. This patient has 5 antral follicles here. Is obviously a expected poor responder, or at least we are not going to have a lot of eggs. However, it's not the same that one that we can see only 1. So immediately we can have a counseling for the patient, we can explain to her what could be the prognosis, and as well, we can get a treatment decision. We can decide what could be the best option to treat this poor responder. If we go with high doses of medication, trying to collect all the follicles, or if we do a modified natural cycle, if only 1 follicle is expected to grow. So it gives to us immediate diagnosis, and also we can make treatment decisions immediately. What are the disadvantages? So all of us, we know that are related to the hardware and the operator variability. The better scan that we have, the more accuracy will be. And also if the patient has obesity or if it's a young patient and we cannot perform a vaginal ultrasound, that also will be a factor that will impact on the accuracy for the antral follicle count. As well, we have some issues with the defining criteria. This is the Bologna criteria for poor responders, but if you read it in detail, it says that antral follicle count between 5 and 7. It's not that they give you a number. It's 5 or 7 or 6, or there's no a very accurate number for that. So what we have to take into consideration for antral follicle count is that we should do a scan with the best technology, with the best machine that we have. As well, we need to evaluate the follicles accurately with the proper technique, doing always the same. The best moment could be when the patient is on day 2, day 3, day 4 of the cycle, where all the follicles are synchronized, and we need to count follicles from 2 to 10 millimeters. It's very important in that point that we have good training for that, and that all the doctors in our centers perform more or less the same, to have a less variability between them. Let's move to the anti-Mullerian hormone. This is always the point that we have more doubts. We have doubts when the patient comes with a blood test from another center, when they do a test in one day, we are like a little bit uncomfortable with the anti-Mullerian hormone. Mainly with the antral follicle count, because we do it in the same moment, we feel like this is more accurate. But anti-Mullerian hormone, although it has some issues, as well is highly accurate to predict the number of eggs at any given ovarian reserve and the stimulation response. It's easy to perform, and as well is fairly non-invasive. It's a blood test. It's easy to do. And one of the advantages from the anti-Mullerian hormone is that we can evaluate as well the ovarian reserve in young patients and on patients that we cannot perform a vaginal ultrasound. So Dr. Fleming, in his review, he was considering that another advantages for anti-Mullerian hormone is that they have a good intercycle consistency and a good inter-operator and inter-cycle consistency. And this is something that we are going to discuss now in detail. So when we have a blood results for anti-Mullerian hormone, we need to focus on different things. We see that we consider that maybe it's not really accurate. We see a value, and then maybe it's not really accurate. It could be because analytical variations, or it could be because biological variations, and these are one of the main questions that we want to solve. So let's focus first on analytical variation. This is an ELISA. ELISA is the technique that we need to do to evaluate anti-Mullerian hormone. So we can have manual ELISAs, semi-manual ELISAs, semi-automated ELISAs, or fully automated analysis. This is second generation, so it's one of the most used assays in the world for AMH, and we need to do a manual ELISA. So if you see here, there are 10 tips for the pipette, 10 tips that we need to move one slide to the other. I did these ELISAs for my PhD, and I can tell you that when I was training for that, the main tip that the technicians were giving me were focus here, because you should not jump any line. You should not miss any line. It's kind of easy. So we have technical difficulties when we do it manually. This is why we have moved to automated assays. I promise I learned, this is me, long time ago. I did it by myself, and I see that the technicalities might be challenging. So if we don't have very reliable technicians in the lab, we don't have a very reliable lab, we can have some issues technical issues, manual issues when we perform the ELISA. But also something more. People consider that when we freeze the sample, there could be variations if we don't freeze the sample, not only freezing or not freezing. This paper shows that if you take the blood sample and you keep it at room temperature in the lab for a few hours or for a few days, the values of anti-Mullerian hormone are 31% higher than if you process the sample immediately. And also they are higher than if you put the blood in the fridge for 4 degrees. Then there is no variability for that. But if you centrifuge the sample and you get the serum, that is where you should analyze the AMH, then you don't have this variability. So it's very important that if they forget the sample's full blood room temperature, or they put it in the fridge, or they get the serum immediately and they process the sample, we will have as well analytical variations. So only these are technicalities, but let's move to the different assays. There are several publications, but this one from Teddy Tadros is one of the most important ones. He compared infertility and sterility, the most 3 important analyses. This is the 2nd generation Beckman culture, and these are the 2 fully automated assays. So the semi-automated assay has 16% higher values compared to Access and 20% higher values compared to Alexis. And between Access and Alexis, 5% of difference as well. So we have difference as well due to the platform, due to the assay that each lab is using. This is why we need to pay attention when we get the report, what is the platform that they have used for the assay. And there is still something extra that we need to pay attention. This is AMH, the way that is produced in the granulosa cells. It's produced as a pre-prohormone. It's not active, and it's secreted to the circulation when some proteases break here, these terminal carbohydrates. So in blood, we have this pro-AMH that is non-active, and to get bind to the receptor 2, it needs to get activated and became the AMH NC terminal. It's breaking here, and then this is the active one. In blood, we have a mixture of the pro-AMH and the AMH NC. And some of the assays, they detect both of them as the same molecule. So we can have different molecules of AMH evaluated as the same level of AMH. Depending on the antibodies that the ELISA assay is going to use to bind in different positions of the hormone, we will detect different levels of this hormone. Maybe the active one only, maybe a mix of both of them. There are some assays, these are the antibodies, they bind in different positions. So we can detect different areas of the AMH. If this molecule is activated or not, we will have different values. This is an assay from Ange lab that has a very accurate antibodies to detect different parts of the AMH. But there is something else. If the patient has a mutation in the molecule of the AMH, there are some areas of the molecule that will not be there. And then the antibodies will not bind, and there will be some AMH circulating in the blood that the assay is not able to detect. So we will have, yes, variabilities due to isoforms, due to the lab, and due to the assay that we use. Now let's move to the biological variations, that also we can have biological variations. So on top of the lab, we can have as well the patient, that is the main one that makes variations. So there was a paper long time ago, 2009, published in Fertility and Sterility that showed that there was a small difference, but statistically significant during the ovulation. So we decide that because this study was done with the second generation and it's a semi-automated assay, let's do with the Alexis, that is a full automated assay, and we will not have these technical variations that we can have with the lab. And what do we see? So we saw that in healthy volunteers, in a full natural cycle, no OCP previously, no hormonal treatment, we saw huge variations during the cycle and 20% intracycle variations. But there is one patient that I want you to focus. This blue line here. These patients start with a level below 1. So this is 2, 1, more or less halfway, 0.5. So this is the moment that the patient has the period, mid-follicular phase, during the LH rise, mid-luteal phase, and the next period. So at the beginning, she starts with a level maybe 0.5. But if you follow during the cycle, she has a variation and ends in the next cycle above 1, maybe 1.3, 1.4. That means that from 0.5 to the next cycle, 1.3, it becomes from a low ovarian reserve patient to a more or less acceptable responder, a good responder. And these are the intercycle variations that also we can see. So in the paper, we saw that from one period to the other, we have almost 30% of intercycle variation. Same patient, same assay, fully automated assay, and we run all the samples at the same time, so only one platform to be used. So these are the real biological fluctuations that we have with the patients. We are human beings, we are different from one month to the other, and we can see it as well with the antral follicle count. Actually, we use it when we want to do fertility treatments, that we do sometimes a scan, we see very, very few antral follicles, and we advise the patient, maybe next month you have few more. And to have from 2 to 4 antral follicle counts is a huge difference for a poor responder. So we decide to start the cycle when they have better prognosis, better number of antral follicles. And we can see it with the antral follicles, and we can see it as well when we give the treatment for the patient, same doses, same patient, and 1 month we collect 10x, and another month we collect 7x. And it's the biological variation that a normal woman have. So then, when we should evaluate, when we should perform an AMH analysis, we think that the best moment is similar to the antral follicle count. During the period, day 2, day 3, they will have the most reliable values. Also, is the moment where then it's better correlated with the number of eggs that we are going to obtain during the cycle, and M2 and fertilized ones. As Professor Fatemi has been discussing before, I will go quickly through these slides because I know that I'm running out of time. There are other factors that have impact on the AMH, and these are genetics, epigenetics, and environmental factors that affect the AMH. And we have been through in his previous slides, ethnicity, body mass index, low levels of vitamin D, if the patient is taking contraceptive, or if she is pregnant, or is a smoker, she's going to have as well different values of AMH. These are different factors. This is something very important because during my PhD, what I published is that when the patient is using gonadotropins for an IVF cycle, the AMH drops during the treatment. And sometimes we see patients that comes from one clinic to the other, they just have done an IVF treatment in another center, and we reevaluate their ovarian reserve. If we perform an AMH during the treatment or just after the treatment, the levels of AMH will be lower because this patient that is doing an IVF, her levels will drop while she is using the gonadotropins, but they will not recover to normal values until she has the next period. And that is just to mention that if she has been a smoker before, or if alcohol use or physical exercise will not modify the levels of AMH. And this is one of the things that he mentioned, the diversity worldwide. This is something that one of the most important publication, The Lancet, has different journals in different areas of the world, because they consider that it's very important to take care of the health in different areas of the world that is different. And this is something that we need to take as well into consideration. What we have here, that ethnicity is a factor due to consanguinity, due to vitamin D, due to BMI, that is affecting this area of the world, maybe in higher prevalence than other areas. And this is something very important to take into account. We have been through these papers before, that consanguinity seems to reduce the ovarian reserve mainly in young patients, that here is the area where we have higher rates of consanguinity as well. Vitamin D and BMI has an important impact on the ovarian reserve. And we go to the conclusions. That is, both antral follicle count and anti-Mullerian hormone are good predictive values for the ovarian reserve of the patients, that there are variations due to the technique and the assay, and we need to take care of the reports when we see them and to know what is the difference between different platforms, different labs, or the moment that the patient has done the treatment, because the biological variations as well are important, and that we have to take into consideration the ethnical factors and the genetic factors that can impact. Thank you.
Thank you, Dr. Laura. We'll open the ground for questions. Please raise your hand.
Thank you very, very much for this very informative lecture and a lot of explanation about the AMH and how much we are facing a question about the AMH actually in our clinic. But just one question. Now we came to know when to measure the AMH, and we can answer the patient about the different value of AMH, but one question. Have you faced, whatever measurement you have used, a difference between AMH level and antral follicular count?
Yes, and this is a very important question, because then what do we rely? And all of us, we have seen that maybe the value of the AMH is very high, and then we do a scan and we see 3 antral follicles, and they are not matching at all. We need to take into consideration then that the patient is not taking contraceptive pills previously, that there is a wash period of enough for the ovaries to recover. And I think that is what I mentioned. What we see is what we are going to get. If we are going to stimulate the patient that month, maybe this antral follicle count has more value in that moment for the treatment of the patient. I don't mean that we have always discrepancies between AMH and antral follicle count, but I think that if we will be able to measure antral follicle count and the same day AMH and get the result the same day, that moment we will have better concordance between both tests than when we do the AMH 2-3 weeks before and then we do an antral follicle count the moment that we want to start the treatment. But yes, it's very important. And I think, in my opinion, that if we are going to start a fertility treatment that month, I will rely in the antral follicle count.
Thank you very much.
Thank you very much, Dr. Laura. I think that will conclude our first session. There's a very quick coffee break for 15 minutes, and we look forward to seeing you back for session 2.
Before we break, may I please ask our 3 esteemed speakers to come on stage for a group picture? Professor Human, Fatemi, Professor Barris, and Dr. Laura, please. And we'll have another group picture with the audience, so please join us in a few seconds.
No, not at all. It's fine. No, it's fine.
Come on.
Picture?
Yes, thank you.
Only men can do this.
No, your microphone is working by you.
Can you please come to the stage for a group picture? Thank you.
Dear colleagues, welcome back to the second session. I'm happy that I don't have any videos now. And unfortunately, Dr. Siba is not able to be here today, so I'll be chairing the session all by myself. And again, our first speaker is Professor Fatimi. And we've just introduced him in detail, so I won't go through his long CV again, and I'd just like to invite him to give his second lecture titled Fresh versus Frozen, Embryo Transfers in the year 2012. Please.
Thank you very much, Professor Boris. In order not to waste too much time, I'm going to start directly with a topic which is heavily debated today, because when you do IVF, the question is, do you have to put back the embryo in a fresh cycle, or do you have to freeze the embryo and put it back in a subsequent cycle? Now, if you take a look around the world, we know that there are around 9 million children born after IVF. In fact, in countries like Denmark, where there is a reimbursement, it's 6% of the total birth of the population born after an ART treatment. And in Europe, it's between 1 and 6% that the population is born after an ART treatment. But we also know that we have more and more cycles which are being frozen. Now this is up to 2013. I can tell you in 2021, 2022, in countries in Western Europe, in the US, more than half of the cycles are frozen cycles. The question is why? Why do we freeze more and more embryos? And the next question is, if you freeze an embryo, how do you put it back? And I think that's an important question. How do you put back the embryo? You will say, okay, they take some pills, or you put it back in a natural cycle. And I think this is exactly the issue. How do you prepare the endometrium to put back that embryo? Because that might make the difference. Before going more into detail, I think we need to understand one very important point, and this is extremely important. The endometrium of a woman is the worst place for an embryo to be in. I'm going to repeat myself. The uterus, the endometrium of a woman, is the worst place for an embryo to be in. You will say, is this guy crazy? He's telling us the uterus is the worst place? Yes. Because if you have a cycle of 28 days, the endometrium is only receptive for around 2 days. 2 days. And these 2 days are defined based on the hours of progesterone exposure. It means the moment your endometrium is exposed to progesterone for certain hours, your window of implantation opens, and after around 48, maybe 50, maybe 55 hours, it closes again. This is very important, but this is being neglected in many publications. Now, if you go back, and this is a publication from 1950, every day of the cycle, every line that you see here is a day of a cycle. You see, every day of a cycle, you have changes of the cells. And if you have a good pathologist, he or she will be able to tell you at every given day on which day of a cycle this woman is at, with a simple biopsy. If you do a biopsy on day 6, day 8, day 13, day 16, day 21, every day the endometrium is changing. Now you might say, this guy is coming to us presenting a paper from 1950. We are more up to date than 1950. The question is it still valid today? And I will show you in a few slides, yes, absolutely, it is still valid today. We know that if a woman is ovulating, there are changes with progesterone. basically just before your ovulation, you have a small peak, but then you have a significant rise of progesterone. And we know that a systemic progesterone level of 0.9 nanogram per ml, a progesterone level of 0.9 nanogram per ml starts the engine. It means it starts the endometrium to be prepared for the window of implantation for these 2 days. So if you look and measure the progesterone values, 80% of women who have a progesterone value of around 0.91, they start what we call secretory transformation of the endometrium. In the follicular phase, you have proliferation. In the luteal phase, you have what we call secretory transformation. And the moment your progesterone reaches 0.9 to 1 nanogram per ml, you start the so-called secretory transformation. Now, if I'm going to ask you, you're sitting in a plane and you are going to land in an airport, would you prefer to land in this long runway, or would you like to land in this runway and a cliff going down a couple of 100 meters? Of course, you prefer to land here, right? You could ask, why is he asking us about the runway and landing? There is a reason why I'm showing you these slides. Now, this is our runway. This is the runway where the embryo can land. And this is the so-called window of implantation. Beautiful paper published in Nature Medicine 2020, 1.5 years ago, 2 years ago. Beautiful paper. What did they publish? They said, look, this is the proliferation of the endometrium. Then you have the ovulation. That is not. You have an opening of the window of implantation. So suddenly, after around 120 hours, your window of implantation opens. It's open, and then it closes again. So this is the area where the endometrium is receptive. This is your airport. This is the place and the time where the endometrium is receptive. If you go here or you go here, there is no implantation. Now, if you take a look at the receptivity of the uterus, you see that this is really based on the hours of progesterone exposure. Having said that, the uterus and the endometrium, they need to be fully synchronized. It's like a puzzle. They need to fit. And if the endometrium is advanced and the embryo is developing slower, they will not match. You will not have any pregnancy. So you need to be fully synchronized in order to have a successful pregnancy. Now, we know one of the reasons why the endometrium is advanced is simply because you have high progesterone. So if during IVF cycle you have a progesterone of above 1, 1.5, you see the pregnancy rates drop. And we published a few papers many years ago looking into the gene expression, progesterone basically low or high. You see, if you have high progesterone, you have a lot of differences in the gene expression. But we know that all women, without exception, all women who undergo IVF, all women, they have endometrial advancement. The endometrium of all women who are being stimulated is advanced. It means your window of implantation is more narrow. Now, why is the endometrium advanced? Why do we have women who undergo IVF having advanced endometrium? Very simple, very simple. Initially, we thought it's because of high estradiol or because the stimulation we do and so on. But today, we know it's not the stimulation. It is because we administer ACG or agonists for the final oocyte maturation, and because we have multifollicular recruitment. So if today your progesterone is 0.6, 0.7, at 4 p.m., and you trigger, let's say, at 6 p.m., at 8 p.m., your progesterone is already 1.3, 1.4, 1.5. So within 2 hours after your final oocyte maturation, you have a rapid rise of progesterone. It means immediately after your trigger shot, your progesterone shoots up. This is a paper Dr. Carroll published very recently, I mean, it was, I think, 2-3 months ago we published this paper. You see, you have a very accelerated rise of progesterone. And if you have an accelerated rise of progesterone, what will happen? Your endometrium will be more advanced. If you compare it with nature, when the patient is ovulating, it takes at least 1.5 days until your progesterone is going up. But with a stimulated cycle with a trigger, within 2 hours, progesterone goes up. Now, we described for the first time around 12, 13 years ago in fertility sterility, the so-called natural cycle for an embryo transfer. But what we have neglected is the fact that if you have progesterone and you measure it in your systemic circulation, let's say it's 0.9 in the systemic circulation. Do you think it is 0.9 in the uterus? No, because the ovary is anatomically very close to the uterus. You have a lot of collateral blood vessels. So the values of progesterone that you have around the uterus is much, much higher than what you see in your systemic circulation. So we know that every woman who is being stimulated and you have a day 5 embryo transfer, the endometrium is not exposed 120 hours to progesterone. The endometrium is exposed almost 150 hours. We are talking about hours of progesterone exposure. And this is why the endometrium of all women who are being stimulated is advanced, at least by 1.5 days, at least. And if it's advanced by more than 2 days, you see the pregnancy rates, they drop significantly. Now, if you take a look at this slide, this is describing the natural cycle. So if you have a natural cycle, basically you have your ovulation, your LH rise. After the LH rise, about 1.5 days to 2 days, you have your progesterone rise. And basically, when you have your blastulation, it's around 120 hours. So you have a very long runway. This is the phase where the embryo can implant. Any time, any hour here, the embryo has the possibility to implant. Okay? But if you take a look now at the stimulated cycle, you stimulate with a trigger, you have immediately your progesterone rise. It means when the embryo is around 120 hours, your endometrium is already 150 hours, which means your runway is significantly shortened. It means you take away the potential of many embryos to implant because you simply have a shorter runway to implant. And this is exactly what has been published in the past, that a natural cycle and stimulated cycles differ significantly. And I think this is one of the best publications in the past 10, 15 years we had. This is from a guy in Las Vegas in the US, Bruce Shapiro is his name. And I think he describes it beautifully. And still we don't understand it. But everything is here. If you have a patient with a nice blastocyst on day 5, the progesterone levels are low. It means the progesterone is well controlled. The embryo is developing beautifully, large blastocyst. In a fresh and frozen cycle, the pregnancy rate is equal, more or less the same. If you have a day 5 blastocyst, progesterone levels are low, but the embryo is developing slightly smaller and slower. You see, in a fresh transfer, you have 50%, but in a frozen, you have 76%. Let's say progesterone is high, day 5 blasto, but large embryo. You see, if progesterone is high, it means your endometrium is already advanced. It's more advanced than it should be. So you see the pregnancy rates are still okay because the blastocyst is developing fast, endometrium is advanced, blastocyst is going fast, still it can catch up, but not that good as it would do in a frozen cycle. Now let's say progesterone is high, but the embryo is developing slow and it's a small blastocyst. Look at the pregnancy rate. In a fresh cycle, 33, in a frozen cycle, 85. Because the runway is so short that that small embryo doesn't have enough space in time to implant. Let's look at an embryo which is day 6. Progesterone low, large, still comparable. But if you go a very slow embryo, day 6, high progesterone, it means endometrium is advanced. It's advanced by more than 1.5, 2 days. Small embryo, in a frozen cycle, you have 73%. In a fresh cycle, 20%. Now you tell me, is fresh equal to frozen? Of course it's not. Because the endometrium is advanced in all stimulated cycles. Here you see that in a graph, beautifully described, and the fact that the endometrium is only receptive for 2 days. This is a paper we published with Dr. Ashna recently in RBM Online. I think it's about 7, 8 months ago, where we looked to the natural cycle and compared it with an HRT cycle. You see, also the cycle regimen is important, how you put back an embryo. Do you use medication to put back an embryo, or do you do it naturally? And you see, in a natural cycle, we have 73% ongoing pregnancy rate. But in a HRT cycle, only 65%. Same population. It means maybe natural cycle is superior to the medicated cycle. Now, Andrea published also from our group very recently, a few months ago, again looking to day 5 and day 6, and we came out with the same findings. But then you could say, but were these studies not done earlier? Because it's a simple study, HRT versus natural cycle. I will tell you, of course they have been done. These studies have been conducted. Meta-analysis has been done. Cochrane meta-analysis. You all know Cochrane meta-analysis. But it's a joke. It's a joke. This is, for example, a Cochrane meta-analysis with one study included, Catoli, 1994. I took for many years, I tried to find that study. And guess what? This study has never been published. It has never been published. It was only presented as an abstract at the meeting, never published as a full paper, and it's included in the Cochrane as a single study. So we have a lack of data in this aspect. Now, to tell you how ridiculous it is, the way we publish papers today. This is a very recent study in human reproduction. We all agree human reproduction is a good journal. It's a high impact factor journal in our field. Now, this paper did a beautiful randomized control trial. Fresh versus frozen in a young population, let's say less than 36, normal body mass index, beautiful population, patients with dream of, because they get pregnant. So they said, is fresh better or frozen? Now, if you listen to me, you would say, of course, fresh is better. But they said, no. Frozen is not good. You should go for fresh. But this is exactly against what I'm telling you now. So I had a look more into detail in that study. I said, how is it possible? Are we so wrong in what we think? So then we looked to the data, and I saw that in the frozen samples, the pregnancy rate in a very good prognosis population was 8%. 8%. In a very good prognosis population, 8%. If in this population, one of our clinics would drop below 80%, we would have a big fight in our clinic. But they had 8%. What does it mean? They simply don't know how to freeze an embryo. But they published it. And by the way, I was told that this clinic has been closed in Netherlands because of very bad results. But still, that has been published. And this is the science that we have today, unfortunately. Now, the fact that the clinic is unable to freeze an embryo, does it mean that fresh is superior to freezing? Of course it's not. Now, when this paper was published, of course, many people commented on that. They said, Shinuhada, what is this? What's going on? We published with Dr. Barbara, a group from Italy, and also Laura Rienzi and Filippo Ubaldi. So many people wrote to Human Reproduction, hey guys, why do you publish this stuff? This should never have been published because it means they are unable to freeze an embryo. Now, we also published a paper in Human Reproduction where we described, unfortunately, in the field of human reproduction, many papers with significant bias and heterogeneity are published. And that's really a big problem in our field, that papers have a lot of heterogeneity. And that is unacceptable because we we go with a conclusion which is possibly not correct. What we need to understand is when you want to synchronize an embryo with an endometrium, you need to respect the hours of progesterone exposure. It means if you have a day 5 embryo, it's 5 plus 1. If you have a day 3 embryo, it's 3 plus 1. You need to always add 1 day to the age of the embryo. Now, I just took another recent paper, I think it's now 3-4 years ago, 2018, and I think we all agree New England is a good journal, New England Journal of Medicine. It's the Bible of medicine. And they compared again fresh versus frozen, and they said, the results are more or less the same. But is it? Are the results really the same? But then you have to take a look at how they calculated the embryo transfer. They completely neglected the basic physiology. So at day 2 or 3 embryos had 2 or 3 days of progesterone. It means all of them had 1 day less of progesterone. And the natural cycle, it was diagnosed with a urine stick. And if they thought that the patient is ovulating, still they had 1 day less of progesterone. But we know that LH rise with a urine stick is not reliable. It is not reliable. You have 30% wrong results. Furthermore, there is a very recent publication. This paper came out last week in Reproduction, very recent publication. And if you take a look, after the LH rise, your progesterone rise, because you're not interested in LH rise, you're interested in progesterone rise. Endometrium prepares based on the hours of progesterone. You see, 22 to 56 hours difference. It means a lady can have an LH rise, progesterone goes up after 22 hours, or she can have an LH rise, progesterone goes up after 56 hours. Was that respected? Absolutely not. So more studies came out recently comparing natural with HRT, and more we are understanding that the natural cycle seems to be superior. So another study, one of the last studies that I'm going into, is a study published in Fertility, Sterility. Another good journal. I mean, Fertility, Sterility is a good journal. So what they did, they said, look, we want to go for an HRT cycle, a frozen cycle, and see if intramuscular progesterone is superior to vaginal progesterone. Very simple study. Very simple study. So if you want to do that study, you give one group intramuscular progesterone, the other group vaginal progesterone. So you have one variable. Your variable is vaginal versus intramuscular. Very simple. And the conclusion was that intramuscular progesterone is superior to vaginal. Now again, this is against all the knowledge that we have today. Why is suddenly intramuscular superior to vaginal? So then we started reading materials and methods. Always in materials and methods, you will find the weaknesses of these studies. So what did they do? They said, look, vaginal, 1, and then in the afternoon of day 5, they put a transfer. It means this group had 4 days of progesterone. Intramuscular, 1 and day 6. It means at 1 day, more progesterone. Come on. Now you have 2 variables. One variable is the days of progesterone exposure. The other variable is vaginal versus intramuscular. How on earth can you publish this? Because you have 2 variables. You did not respect the hours of progesterone exposure, and you draw conclusion, and even the reviewers, the editor and associate editor of this journal didn't get it. But unfortunately, this is where we are in our field, that we have a big gap of knowledge, basic knowledge. Now, we know, for example, that if you compare fresh with frozen, that with fresh you also have more ectopics. But an interesting point are the complications. And one of the complications that we thought we have with frozen is large for gestational age, hypertension, and postpartum hemorrhage. But the question is this linked to freezing, or is it linked to the cycle we put back the embryo? And it seems that this is not linked to the freezing. This is linked to the fact that we use a lot of medicated cycles and not natural cycles. Because if you have a natural cycle, you have a corpus luteum. If you have a corpus luteum, your corpus luteum produces something which is called relaxin. And it seems that this relaxin has an important function. The The function is also to control the blood pressure of a woman. And you see, if you don't have a corpus luteum, you have a lack of relaxin. But this is what is happening if you have a corpus luteum. So if you compare the complication, large for gestational age, or hypertension, preeclampsia, and other complications, it is not increased if you put back the embryo in a natural cycle, but it is increased if you use it in a medicated cycle. So even if you speak about frozen, you need to define what frozen are we talking about. Is it a medicated or is it a natural cycle? And more papers came out, and everyone is showing the same thing. If you use a medicated cycle, you have more complications. But if you use a full natural cycle, most, if not all of these complications can be avoided. So the question is today, do you want your child to grow up here or here? Stimulated cycle, natural cycle. Thank you very much for your attention.
Right, I mean, we thank you for this nice capturing presentation, which is comprehensive. And we have time for a few questions. If you would like to ask any questions, any comments, contributions. Okay, so let me then start with one. Yeah, I mean, as you said, these urinary LH kits are often used in Europe and in other countries as a surrogate for progesterone. One other problem with those is sometimes they turn positive, but the woman does not ovulate. So how does it happen, or is there a way to understand whether she will really ovulate or not after that positive LH kit on urine?
Yeah, I mean, the problem with these LH kits is, even if you have, let's say you detect the ovulation, let's say you detect there is an LH rise, you have seen that with your LH rise, you don't have always the same pattern of progesterone rise. So you can have a progesterone rise, let's say 22 hours after your initial LH rise, up to 56 hours. So already here you have 30 hours of difference if you would detect correctly the LH rise. But there is also technical problems with these sticks. As you have seen, there is 30% wrong detection. So first of all, 30% wrong detection and 30% variation with progesterone rise. So that means more than half of the cases, you have no clue when the patient ovulated. And at the end, we have seen the window of implantation is based on the hours of progesterone exposure. And of course, if you don't know how many hours the endometrium has been exposed to progesterone, you don't know when the window of implantation has opened. And I think this is one of the weaknesses with most of the studies that we have in the frozen cycles.
Especially also, could be a problem with PCOS patients as well. High endogenous LH could often turn positive.
Yes.
Any other questions? Yeah, there's one.
Thank you very much. It's certainly an eye-opener, and I'm going to look into changing my practice. So what I got out of what you've just said is we should be going towards frozen rather than fresh, but not only frozen, we should consider the natural cycle. But I still go back to the pitfalls we have with the natural cycle, because you cannot control the variables that you've just highlighted. So in essence, I'm asking you, what is your practice in your clinic, and how do you overcome these issues, and what do you actually do?
You said it better than I could ever have said the whole presentation, so thank you for that. Now, how do we do a natural cycle? If a patient is having a cycle of, let's say, between 25, 26 days to 34, 35 days, we tell them we would like to go with a natural cycle. However, the problem with the natural cycle is women who are stressed, the stress might postpone an ovulation or prevent an ovulation. So 20 to 25%, we have published this data, of women, they will not ovulate. So we inform them, look, even if you go with a natural cycle, there is 20-25% risk that you would not ovulate. But they will tell you, yes, doctor, but I ovulate every month. I can put my watch and I know I'm going to ovulate, but then they don't ovulate because they're stressed. So we inform them about that in advance. Now, once they agreed and we agreed that we go with a natural cycle, what we do a follow-up of the cycle without any blood tests. First, we do a scan day 2 or 3 of the cycle, make sure there is no persistent corpus luteum. Hear me? Yes, now it's back. We do a scan day 2 or 3 of the cycle, make sure that there is no persistent cyst or corpus luteum. Then we see back the patient between day 10 and 12, day 10 to day 12. If we see there is a follicle growing, let's say there is a dominant follicle, 14, 15 millimeters, we want to know how much hormones does this follicle produce. Because every follicle has a different capability of producing steroids. Some produce high levels of estradiol, some produce less. So we want to know how much estradiol this follicle is producing. So we measure estradiol and we measure progesterone of this patient. So we make sure progesterone is low, let's say 0.2, 0.3, and how much estradiol the patient has. Now we know that if a patient is ovulating, it's not that LH goes up and progesterone goes up. I don't know if you have seen the slide of Dr. Lawrence's publication with the arrows up and down. The patient doesn't need to do every day a blood test because you would say, I don't want to miss when she's ovulating. Basically, how do patients ovulate? When the follicle is around 17, 18, 19 millimeters, you have a rise of LH. But the rise of LH, if you would check the blood on that day, you would see LH is going up, but estradiol is even further going up compared to what you did 3-4 days before. So let's say your estradiol is 150 3 days before, and after 3 days it's 250 or 300. It means this is the beginning of ovulation. So the patient didn't ovulate yet. Now it might be that you capture it the day after, that yesterday LH went up, but estradiol starts to drop, but progesterone is still low. It means you have high LH, drop of estradiol, but progesterone is still low, 0.3, 0.4. That means you have captured the ovulation the second day. Or the third day, what is happening of the ovulation, LH is still elevated, your estradiol crashes down very low, maybe 70, 80, but your progesterone starts to go up, 1.3, 1.4, 1.5. So this is the time that we would consider day 0. This is the time of ovulation, and we calculate it from there. So you don't need to do every day a blood test with a patient. It means you just do a blood test with a follicle of 14, 15 millimeters, and then every 3 days, just to capture, and based on one of these 3 values, you know where the patient is in. And then you can take it from there and calculate when you do the transfer.
Thank you.
Can I just add?
Sure,
that's very interesting. I'm going to move on to the frozen cycle. And are you following, the latest fads that looking at compaction of the endometrium and measuring the progesterone levels?
So these are not the latest facts, these are outdated facts. So initially, the first person who published about compaction of endometrium is the group of Bob Casper from Canada. And after that, many, many publications came out looking into that, looking into progesterone and the pattern of compaction. And all the studies which came out over the past 3-4 years, none of them confirmed the findings that compaction is predictive. The latest publication is, I think, 2-3 weeks ago, I think Infertility, Sterility, or Human Reproduction, one of these journals. They looked into that and they failed to see that compaction has an impact. The first who did it was Bob Casper. After that, I think 3-4 publications came out the last 3-4 years, and none of them confirmed these findings again.
All right. Okay, so maybe just one more question if you have, or we can move to the next speech. Thank you so much.
Thank you
for
very
all
much.
the energy, your comprehensive and capturing presentation. Okay. So the next speaker is Dr. Carol Kaplan, with whom I have the privilege to work together with. She is a Royal College of Obstetricians and Gynecologists accredited subspecialist in reproductive medicine and surgery. She graduated with honors from the University College Cork, Ireland in 1997. She was awarded Doctor of Medicine degree in July 2013 from the University of Sheffield, the UK. And her thesis was focused on recurrent implantation failure and recurrent miscarriages, resulting in many publications and presentations both nationally and internationally. She has an interest in fertility preservation, particularly for oncologic patients, and prior to relocating to UAE, she was the clinical director at Rotunda IVF, the National Oncofertility Center, at Rotunda Hospital, Dublin, Ireland. And the title of her lecture is can you ever have too many oocytes? So please, Carol.
Thank you. Thank you very much for that very kind introduction. Good evening, ladies and gentlemen, colleagues. Today I'm going to discuss about one of the most basic instrumental aspects of reproductive medicine, oocytes. So, I just get back. Okay. So, the aim of in vitro fertilization treatment is to achieve a term live birth. And one of the biggest prognostic indicators for this is the number of oocytes that we retrieve. And naturally, the IVF treatment protocols are aimed to optimize this outcome. But in actual fact, our understanding of the number of oocytes in relation to live birth really has not been very well understood for many years. So we're going to take a little look through the available evidence. So this was a published paper going back some time. It looked at all the anonymized data on all IVF cycles that were completed in the UK between the year 1991 and 2008. So it was essentially an historical database looking at live birth rates and oocyte numbers. Just to emphasize that all this data was based on fresh embryo transfers. That's where we transfer the embryos 2 to 3 days or a few days after the egg collection. So here we can see that what they found is that approximately up to 15 eggs would optimize the outcome of a live birth in a fresh transfer. And you can see very easily from this graph that the live birth rates increased with the increasing number of eggs up to 15. Then there's an obvious plateau between 15 and 20 oocytes, and then a decline after that. There were 2 further studies, again reviewing historical databases. The first was the live birth rate associated with repeat in vitro fertilization cycles. So these were looked at as individual cycles, the first, the second, the third, and very importantly, all fresh embryo transfers, and plotted against the number of oocytes that were retrieved in the very first cycle. Just one very interesting thing to see. In the first cycle, where ladies retrieved no oocytes, in their second and third cycle, there was actually a live birth rate of 20%. But that's just an aside. But here we can see, again, with the increasing number of eggs, there was an increasing number of live birth rate, up to approximately 15, again in this paper. But again, to reiterate, these were all fresh embryo transfers. And again, an historical database from 2003 to 2010. And the final paper here predicted the chances of a live birth after 1 or more complete cycles of IVF. Again, an historical database, 1999 to 2008, from the HFEA in the UK. And here we can see that up to 13 eggs, then we can see a plateau. So the live birth rate was increasing. So this title caught my attention because it really highlights the futility of reviewing historical databases, particularly when we see a change in our clinical practice during that time. So what has changed? And what we have seen is the introduction of cryopreservation for gametes and for embryos. And even the methods of cryopreservation have changed. Initially, we were dealing with what we called slow freezing, which was freezing at a sufficiently slow rate to allow cellular dehydration while minimizing the amount of ice formation within the cells. We then progressed to vitrification, which allows the solidification of the cells and the extracellular milieu into a glass-like solid state with no ice formation. And the RCTs have shown that with vitrification, the cryosurvival rates are better and also the clinical outcomes. So, what has vitrification meant to us in reproductive medicine? And this paper here makes it so obvious. When you look at the blue line, this is the live birth rates in the fresh cycles, so the fresh live birth rates. The red line indicates the cumulative live birth rates, which consists of both the fresh and the warming cycles. And here you can see the obvious difference. What's really interesting, though, is in the fresh live birth rates, when you achieved about approximately 15 eggs, then you could really see the impact here of freezing to about 80%. And this can be attributed to the elective freeze-all to ensure the safety of the cycles for the patients. Now we're going to fast forward to 2018 to Polizos and his group, and this was the largest multi-center study that looked at egg numbers in relation to cumulative live birth rates. And what we can see here are the two shades of blue. The lighter blue is corresponding to the fresh live birth rates, and the darker blue to the cumulative live birth rates consisting of the fresh and the frozen cycles. And again, here the difference is so easy to see. With the fresh live birth rates, you can see that up to about 15 eggs, again, there is a plateau, and even up to 20, and then we see a decline. But with the cumulative live birth rates, there's a continuous trajectory upwards in line with the increasing number of eggs. So the take-home message from Polizos and his group was really that ovarian stimulation does not adversely affect the oocyte quality, the embryo quality, and the cumulative live birth rates. And this is a further study that looks at how many eggs do we need to maximize the cumulative live birth rate. And this was a retrospective population-based cohort study, and they divided the women into different age groups. And what they found was that from women aged 18 to 35, that they achieved a maximum cumulative live birth rate with 25 eggs. For those aged 36 to 44, 30 oocytes, and for women over 45 and above, if they had achieved 9 oocytes at retrieval. So now we know, we've answered the question. Ovarian stimulation, high oocyte numbers, will not affect the oocyte quality, the embryo quality, and will enhance the cumulative live birth rates. But will it adversely affect embryo euploidy? And my colleague, Professor Boris, and his group had published a paper, and this table here is showing some published and unpublished data. So they looked at CGH results of 7,753 embryos from 990 patients. And what they found is that as women aged, the incidence of having embryonic euploidy significantly decreased. But for each additional embryo that you have, the chance of having an embryo which is euploid is actually significantly increased. This is really easy to see with the increased number of blastocysts that are available. There is no adverse effect on embryonic euploidy. Now, the dose of gonadotropin that we are using, does that adversely affect the oocyte quality, the embryo quality, or the live birth rates? And this is very good news for clinicians and for their patients, because we do tend to increase the dose for poor responders, women of advanced age, and there is no evidence that by increasing the dose, we are adversely affecting the treatment success. And this again is a further study to look at embryo euploidy. And again, it's so reassuring for clinicians and their patients. There is no evidence that the dose of the gonadotropin, the duration of time that we are using it, the estradiol level, the size of the follicles at trigger will adversely affect the embryo euploidy rates. So now we know that ovarian stimulation will not affect the egg quality, will not affect the embryo quality, and will enhance the cumulative live birth rates. But what are the safety issues for our patients? So I'm going to revert back to Polizos and his group in 2018 when he looked at the ovarian hyperstimulation rates in his study group. An OHSS, it's an iatrogenic complication of assisted reproduction, which unfortunately can be potentially life-threatening. So it can be quite serious if not managed appropriately. So in his paper, he broke down the number of oocytes into different groups and then looked at the incidence of moderate to severe OHSS within those groups. And you can see that the incidence is actually quite low in the group. So of those who achieved 1 to 3 eggs, there was a 0% incidence. 4 to 9, 0.04%. 10 to 15, 0.26. And here increases 15 to 25, 1.12, and greater than 25, 2.96. But what is really important here to note is that all of these women who were diagnosed with OHSS had all received HCG, either as trigger or as part of a modified luteal support program. So again, my colleague, Professor Boris, published another paper where he looked at all the modalities that can be used to prevent ovarian hyperstimulation syndrome. OHSS, it's so well published in terms of the diagnosis, the management, but actually there's been very little attention paid to the modalities that we can use to either ameliorate it or to reduce the severity of it. So, in summary, what Professor Boris and his group had suggested was that all women at risk of hyperresponse should be treated with the antagonist protocol. They should be triggered with the GnRH agonist as opposed to HCG with an elective freeze-all plan. And the additional modalities that we can use are the introduction of a dopaminergic agent, and we could prescribe that either at the time of the trigger, just before the trigger, or on the day of the egg collection. And also the antagonist can be restarted in the luteal phase just after the egg collection. And what his study had looked at 170 hyper-responders, and if they had followed that type of regime and received those extra modalities of treatment, then they were found to have their menses 7 days earlier, smaller ovarian diameters, and less hemoconcentration and higher sodium levels. So now we look at the perinatal risks. Does ovarian stimulation, high number of eggs, have any risks for the babies? And Sankara's group, again, had looked at this, and they said that it does. They said that if you have a high number of eggs, you're at an increased risk of a preterm birth and a low birth weight. But what is interesting is if you really read that paper and looked at the methodology of it, they did include some confounders, but actually some very important confounders were not included. Things like BMI, smoking, the medical history of the woman during her pregnancy, and there was no mention of PCOS. Another paper was published which totally contradicted Sankara and their group, and this paper included those important confounders. So there was no risk of preterm birth. There is no risk of low birth weight. But what is interesting is they found an increased risk of placenta previa. But what I do want to highlight is in this paper, they were all fresh embryo transfers. So what you could maybe interpret is that it's the stimulation per se may affect the implantation site, but I think that needs further research. So here, just to highlight the difference in the two papers and how one paper had included these very important confounders, but the other paper had not. And then we found two very contradictory results. And last but not least, ovarian torsion. Seldom mentioned, but very significant effects if it does occur for a lady. And this paper had shown that if we do use the GnRH agonist trigger, it will reduce the risk of ovarian torsion for ladies who have very large enlarged ovaries following ovarian stimulation. So, in conclusion, the cumulative live birth rate per collection is the ultimate measure of success. Stronger stimulation and collection of a higher number of oocytes do not affect euploidy rates, but increase the chances of having at least one euploid embryo. Higher number of oocytes are not associated with adverse obstetric and perinatal outcomes. So it's very important. Couples are investing a lot emotionally, physically, financially into the treatment. It's very important that we get it right the first time. Less is only more where more is no good. Thank you.
Thank you. I mean, very nice presentation, and even you finished a bit earlier, leaving a lot of time for questions. And now we're looking forward to questions and comments. Okay, so, all right, maybe, please.
Thank you, Dr. Carol. Another question, the frequent stimulation and the more egg retrieved does affect the time of menopause?
Not at all. No, not at all. So going through IVF cycles will not accelerate your ovarian aging. In the same way, if you were taking a contraceptive pill for years, it's not protective. So I can reassure, patients about that going through IVF will not accelerate or bring forward the menopause.
Okay, and there we have a group of patients who have a breast mass with family history of breast cancer, and it's not clear whether it is hereditary or hormonal dependent. Would you go for less trigger, less hormonal treatment, or you prefer to do it one time?
That's a good question. And with fertility preservation, we're doing an offering cryopreservation of embryos and oocytes, even for ladies with breast cancer, before they go through their treatment. And what we can do is prescribe letrozole during the treatment cycle, which will keep the estrogen levels really low, but won't adversely affect the treatment cycle itself. And we can use the antagonist protocol and a GnRH agonist for trigger. So breast cancer per se is not a contraindication. We do use it for oncology cases. We can offer the treatment. Patients with a family history, whether we know whether they're carriers or not of the genetic risk, can also be offered letrozole. So we can do it safely.
Thank you, Dr. Carroll, for this detailed evaluation and presentation. You referred to Sunkara's paper, which is a huge database from HFEA looking to hundreds of thousands of cycles and coming up with a magic number of 15, which honestly, personally, I don't think is correct. However, do you think the stimulation that we do, because you mentioned the stimulation has no influence or multifollicular recruitment has no influence, do you think the systemic FSH level on the day of final oocyte maturation has an impact on aneuploidy of an embryo? With other words, the way we stimulate and the systemic level of FSH of a certain patient on the day of trigger, does that possibly create more aneuploidy because we didn't stimulate correctly?
The evidence about that is by no means conclusive. My own feeling is no. I think the evidence that we have is pointing towards increasing the number of eggs to give the woman the best chance of having a euploid embryo. However, I do think the method of stimulation is very important, that we do get the best quality get the best quality eggs that we can. And I know our group within AORT Fertility have done a lot of work. My colleague, Dr. Barbara Laurence, has been looking at step down of gonadotrophin levels to make sure that the FSH levels are maximal, to ensure we're getting the best stimulation, but not overly high, which can lead to high progesterone levels. And there has been one paper published that has suggested that if the progesterone levels are high on the day of trigger, it may have an adverse effect on the egg quality, which may then translate into lower pregnancy rates. I'm not so sure of euploidy rates. I don't think so, but maybe the quality.
So you know, we have this year, next week at ESHRE, I think 11 abstracts accepted, and one of them is from Dr. Raquel. And the topic, maybe you can explain it, maybe you're not aware of it, Dr. Carol, but maybe Dr. Raquel, you can explain something which is going to be published next week, the possible impact of systemic FSH of aneuploidy.
Thank you, doctor. So we just published that the increased levels of systemic FSH in the day of the trigger, so at the end of the stimulation, could affect the euploidy rate of the cord in the end. So higher FSH levels are reducing the euploidy rate of the cord.
Okay. Yeah, it's very interesting. It's novel. It suggests an association. But I mean, necessarily causal. We need to look into the mechanism as well. The former studies, they just look at FSH, the injected FSH level. I mean, not level, but I mean the units of total exposure. And the systemic levels may be very different for different women. And so it's a different way to look at it. And I mean, your database is amazing, provides a lot of insight.
But true, patient characteristics may affect a lot.
I mean, systemic FSH, the level in circulation is affected by the amount we inject and also the amount of FSH that is captured by the receptors. So the FSH that's not captured once the receptors are satisfied, that still remain in circulation, also reflects. So it's whether it's FSH itself, it's follicles or receptors. It's an interesting association to explore further. Thank you. Any other questions? Comments? Okay. Thank you for the nice presentation. For the sake of time. Okay. So now it's my pleasure to, I have some technical issues today. It's my pleasure to announce next speaker, Dr. Francisco Ruiz, who is an IVF specialist. We are working together. We share the pleasure of working together. And Luis has graduated from Universidad Nacional Autónoma de Mexico, if I'm pronouncing correctly. And he received a degree of Master's in Human Reproduction from Universidad Rey Juan Carlos in Spain. And he did an IVF fellowship at IVI Madrid with Dr. Velasco, I believe. And he recently completed a postgraduate certificate program at Harvard Medical School. And he's been working in IVI Madrid as former IVI Middle East and was director of ART Fertility Muscat and now back to Abu Dhabi. And he'll be giving a talk on the effect of COVID-19 on human reproduction. Please, Francisco.
Yeah, thank you, Dr. Barise, for the kind introduction. And thank you also for the invitation, and congratulations to Merck for the nice organization and the beautiful setting that we have. And it's always nice to see all my colleagues and people that I worked with before, so thank you. And so today we're going to be talking about COVID and reproduction. And we know that this is something that we have all heard for the last 2 years. It has impacted the lives of every person in the world. Many of us have lost dear ones to this condition, so it's a very important topic. And Reflecting on COVID, we know that the first cases appeared in late 2019. Maybe the spillover event occurred then. We know that the virus was sequenced in January 2020. We know that it not only affects the lungs, but it can affect many organ systems in the body. And we know that it came from an animal to a human, of zoonotic origin. And there are reports that because of global warming, there might be more pandemics coming as well. So not to be pessimistic, but maybe we are bracing for more pandemics in our lifetime. So the objective of the lecture today is just to focus on the impact of first infection and then COVID-19 vaccination, the impact that both of them have on pregnancy, on human reproduction, and also on ART outcomes, on assisted reproductive outcomes. So this is mainly the objective of the lecture. So first, some basics, because this is important. We need to know how the virus enters the cell so we can know where the virus can go, what tissues it can infect. So mainly the way that the virus enters the cell is by this mechanism. So it needs a receptor, which is this enzyme, the ACE2, and the spike protein in the virus goes to this receptor. So that's how it gets attached to the cell. And then it needs a protease. It's a little bit difficult to name, TMPRSS2. But basically, it needs to cut the spike protein so the cell can involve the virus inside. So this is the basic mechanism. There's other mechanisms involved, possibly, with the BSG, but this is the main mechanism. And I wanted to show you these two videos as well. This was done as a simulation performed in a supercomputer in the US. It was from the University of California, although the computer is in the other side of the country. And you can see here how the virus travels in an aerosol. So the aerosol is basically almost the same size of the viral particle, as you can see. And it's protected with also mucins and maybe the surfactants and fluids from the lung. So that's how it can travel and go all the way around the room. No? And you can see here the spike protein, and possibly is protected by all these mucins and the surfactants as well. So this is mainly the biggest way of how it transmits airborne. The current situation worldwide, we know that there has been more than 500 million infections, or confirmed infections at least. We know that there has been more than 6 million confirmed deaths as well. This is the official numbers. And just to get a perspective as well, recently it was reported that in the US, by February 2022, more than 60% of the population had already been infected, and 75% of the children. So this is just to see how big this has been, infecting many, many people, no more than half of the population. And in UAE, we know that it has been more than almost 1 million confirmed cases, more than 2,000 deaths. And recently it was reported by the WHO that the real number of deaths is not really 6 million, possibly it's more than 15 million deaths. This is checking the excess mortality rates in the different countries. So it has been a much bigger, or has had a much bigger impact than officially confirmed. There has also been other ways that it has impacted this virus to fertility, even in an indirect way, with many possible mechanisms. But one of these is in the fertility rates, or the live births as well in different countries. So in Europe, it was reported that the live births went down after the containments, and also affecting the fertility rates. Dr. Fatemi already spoke about this before, how the fertility rates have been decreasing here in the UAE. And lately, you can see a big drop to 1.3, and now in 2022, no, according to macro trends. So we see an indirect impact as well on fertility rates. This is from 3 days ago. Now we know that some cases are coming back, the numbers are high, and it doesn't seem that this pandemic will end. No? But it is true that this pandemic is different 2 years ago from what it is now. No? And this is because of science. So because of science, the scientific community was able to create this vaccine very rapidly, very good vaccines as well, that can protect us against COVID-19. So it's a very different situation now than 2 years ago. And initially, all the fertility societies, when the pandemic started, we really didn't know how to act. No, we didn't have much information about it, about the virus and how it can affect fertility. So the initial advice was to stop all treatments, maybe only for patients with cancer that needed to freeze oocytes, but basically halt everything. Some clinics even closed for about 3 months, so it was a big impact on many patients. Not that they wanted to start their treatments, they had to delay, maybe with low ovarian reserve, so it was a big hit. But it was, you can say, draconian measures or very extreme measures, but it was what it had to do. We had to put some resources to the system, especially in the ER, to have more doctors for that. But later, more information came, and we knew it was safe to start the treatment. No? So most clinics started again to offer the fertility treatments. What is the impact of the infection of COVID-19 in pregnancy? Well, we know it has a big impact. We know that women that are pregnant and get the infection have a higher risk of severe disease, of going into the ICU, of intubation, even death. So it can have a big impact. No? And we know that it can create or be a risk factor for preterm birth. This is one of the most important ones. And also preeclampsia. And it doesn't seem to be vertical transmission, which is a good thing. So that appears to be very uncommon. But it can have a big impact in pregnancy, the infection itself. We know that early miscarriage doesn't seem to be increased if a woman gets the infection. There has been some conflicting reports on this, but mostly all studies point towards that there's no increased risk of early miscarriage. What is the impact of COVID-19, the infection, before IVF treatment? Basically on human reproduction, what is the impact? We know that most studies point towards no co-expression of these two, the receptor and the protease. Remember that we mentioned that we need these two in the cells for the virus to enter. So the myometrium, the uterus, the ovaries, or the fallopian tubes doesn't seem to co-express these two. So that's reassuring. But the oocytes and late blastocysts appear to express these two molecules, the receptor and the protease. So potentially the eggs can be infected by the virus, and also the embryos. No? So far, some studies have shown that the oocytes in patients that were positive for COVID, they didn't see any RNA particles. So this is also reassuring. And for now, I'm not aware of any studies that have checked into the embryos. I don't know if Dr. Varis, you're aware of that, but so far, I'm not aware of any studies that have checked the embryos themselves. Also, in some studies, they haven't confirmed in the follicular fluid any viral particles, only antibodies against the virus. Then there can be some menstrual cycle disturbances. These are usually transient, they are not permanent. And it could be between the cycle days and also the length of the menstruation. And there doesn't seem to be an impact on the ovarian reserve, at least from the AMH and antral follicle count, and before and after the infection. It seems that there's no impact. And it doesn't seem to be a sexual transmission, at least from woman to men. In most samples that have been tested, vaginal samples, there doesn't seem to be viral particles, although there's some reports that have seen it, but basically it's considered a known that is not transmitted sexually. Then what about ART? If a woman gets an infection, will this have an impact on the assisted reproductive technology results? Well, at least in the fresh cycles, it doesn't seem to have. There has been some reports already that when they were matched to patients that didn't have the infection, there's no difference in clinical pregnancy rates. So there doesn't seem to be an impact, at least on fresh, and also in frozen embryo transfers. No? So people that were infected, people that were vaccinated, and people that were not either vaccinated or infected, there were no difference in clinical pregnancy rates between these three groups. And there was especially here a group that had only euploid embryos, and there was no difference between the three. So again, this is something good to know, that doesn't seem to have an impact, the infection, on frozen embryo transfer. What is the impact of vaccination on fertility? If a person gets vaccinated, will this have an impact on the fertility or on the outcome of treatments? Well, here it happened something particular, that at the very beginning, in the clinical trials for the vaccines, we didn't have information for pregnant patients. No, they were not included in the trials, so there was a gap of knowledge there. And also there were some people in Europe that sent a petition to the medicine regulators in Europe asking to halt the clinical trials. No? And this did a lot of damage because there was a lot of misinformation online, and many people were doubtful of getting the vaccine because of the risk of the impact on fertility, getting sterile, but they did this without providing any evidence. No? Now we have more information and we know that that is not true, and I will show you why. This is a similar study from the previous one that we saw. This was comparing women that were infected with COVID, women that were vaccinated, and women that didn't have the infection or were vaccinated. So there were also no difference in implantation, clinical, and pregnancy rates. So there was practically no difference at all. Also, the impact of the vaccine and IVF outcome, it doesn't seem to be a difference in the number of oocytes collected, in the number of mature oocytes collected, in the fertilization rate, in the number of top quality embryos. So there doesn't seem to be a difference between infected and uninfected women, at least with the mRNA vaccines. Also, something that has been reported is just like the infection has an impact on the menstrual cycle, also vaccination has an impact on the menstrual cycle, but not on the length of menstruation, but on the length of the cycle. No? You can see here after the first and the second dose, maybe it can delay almost a day. But this also appears to be transient, it's nothing permanent. And also, what is the impact of vaccination of ovarian reserve? Just like the infection didn't have or appear to have an impact on ovarian reserve, also the vaccination doesn't seem to have an impact on that, and at least from the AMH level. So before getting the vaccination and after the vaccination, the levels of AMH were comparable. No difference was seen. The safety of the vaccines in pregnancy, also there's more information now. There was an initial report in the New England Journal of Medicine with patients that were pregnant in every trimester, and the vaccine seems very safe as well. So it appears to be when a woman receives a vaccination during the pregnancy, it appears to be highly immunogenic. It creates a good response against COVID. It is effective on preventing it. We don't see any significant adverse events when women that are pregnant get the vaccination, and no increase of spontaneous abortion. And sometimes it has been reported that there's some antibodies in the blood of the cord, so potentially helping the newborn as well. This is the WHO, the recommendation that they recommend that all pregnant women should be vaccinated. And these are all the vaccines that are actually possible to be given during the pregnancy. Only Novavax, if you have any other vaccine, better, but all of them are practically recommended during the pregnancy. No? The data is reassuring. What about men? We have talked about the impact on women, but what about men? So we know that testosterone levels are somehow related to the severity of the disease. It has been shown that lower levels of testosterone is related to a higher or more severe COVID disease. We don't really know what is the exact mechanism. We know that in men is usually more severe COVID than in women, but we don't know the exact mechanism. And also when COVID is present, testosterone levels also tend to go down. So, but we don't know the exact mechanism for that. But it could be as a marker maybe of severity. No? We know that men with lower testosterone levels will have a higher chance to go into ICU or even death. Then what we see, and this is for the practical purpose as well in our practice, is that it has a negative impact on the parameters of the semen analysis. Many studies point towards a lower concentration of the sperm and lower motility. But this appears not to be permanent, which is a good thing, of course, and maybe after one cycle of spermatogenesis, 2.5 months or 3, then all the parameters tend to go back to normal. But this has an impact on this. Most of the studies haven't shown or that there's viral particles present in semen, especially in mild or moderate disease. In severe disease, some reports have been there, but basically we can also consider that it's not a sexually transmitted disease, now this time from man to woman. There has been some autopsy study that they have shown viral particles in the testicle. So we still don't know how it can affect these parameters in the semen, if it's in an indirect way, if it's because of fever or why, but we know there's a direct impact. And the vaccines in men appear to be safe, appear to be as effective, and we don't see, different from the infection, we don't see an impact on the semen parameters when a patient receives an injection, a male patient. And these are the latest pronunciations or advices from regarding COVID and the fertility societies around the world. This is from ESHRE. So triage and testing is not anymore advised. Many patients can go to the clinic and start treatment. Then it is always best to offer the patients vaccination, no? Especially if they are trying to become pregnant, because we know the risks of COVID, the condition, during pregnancy for mother and baby. So it's always important to offer vaccination. But they say that we shouldn't or stop offering the treatment even if they are not vaccinated. For the ASRM, it's the same. So they encourage all people to become vaccinated. So you see the same topic, no? They are encouraging all patients to become vaccinated, no? To protect them during the pregnancy and the newborn as well. And this is another important thing that we saw in the pandemic. We saw that telemedicine was possible, no? Before we were really not using it that much, but now we saw that it is an effective way to be in contact with patients, maybe even doing certain consultations. So telemedicine is maybe here to stay. So this has been a positive thing of the pandemic. And the American College of Obstetrics and Gynecology, then the same. They say that we should inform women that want to become pregnant to get the vaccination. No? This is basically the message of all societies. And just to summarize, these are the points that I think is important to remember today. So that COVID, the infection, has severe consequences in pregnancy. Second, we know that there's no sexual transmission, most likely, that there's no impact of the infection, and also vaccination on ovarian reserve, that also infection and vaccination both may have an impact on the menstrual cycle, but this is only transient, that there's no impact on pregnancy rates in fresh IVF after the infection, and after infection and vaccination, there's no impact also in frozen embryo transfer. So you see that in general, there's practically no impact on ART outcomes, either with infection or with vaccination. And as I mentioned before, probably this is the most important point for in our practice, that there can be an impact on the sperm parameters when a man has the infection. Some authors have even suggested that we should wait even 3 months before we start a new treatment, but this is no official recommendation. And also the safety of vaccines in pregnancy, well, we have more information now. We know they are safe, and then they really help, and they are immunogenic, and that they should be offered to all women that want to become pregnant. No? So vaccines are very effective. They can prevent severe disease in the pregnancy, and these are basically the recommendations. Mm-hmm. So thank you. Mm-hmm.
Mm-hmm. Dr. Ruiz, dear friend, thank you. I mean,
I don't know if it was too fast,
in just 19 minutes, you really covered everything from male, female, pregnancy, IVF, obstetric complications, vaccination. Thanks a lot. Any questions, any comments, anything unclear? Yes, please. Can we have the mic? Allah, here.
Thank you so much for this lecture, and very informative. About menstrual cycle, yes, we noticed that sometimes it causes delay, sometimes frequent menstruation, sometimes excessive menstruation. But what was the mechanism for COVID to do this?
We don't really know, and then there could be another mechanism, which could be anxiety and stress. Just
but
Dr.
but the changes are between patient and other, they all not the same even.
We don't really know, but one factor that could be related could be even stress, because when the infection is there, they are stressed as well. There's anxiety, so that is well known that it can.
But
have
stress
an
may
impact.
be okay. I mean, or a delayed menstruation, but excessive menstruation also stress, frequent.
But the truth is that we don't know, unless
don't
you know
know.
something different. But it's what
don't
now.
know.
It's a systemic disease.
Yeah.
And it affects other endocrine organs as well. It causes transient thyroid dysfunction even, right? So ovulation is coordinated by so many things. So some patients may have, their thyroid affected, which may indirectly affect ovulation. Their systemic general condition affects ovulation. So menstrual cycle is affected by so many things, but I think the good news is whatever happens, so far it seems transient. So
they didn't discover something in the ovary specifically.
No, I mean, it doesn't seem to infect, like ovaries any differently than any other organ. It doesn't seem to harm ovarian reserve. So I think it's an indirect effect through, through the effects of the infection on women's body in general, and even possibly through thyroid dysfunction.
Maybe. Thank you.
Pleasure. Please.
Hi, my name is Dr. Albatul. I'm from Aster Clinics.
Hi, doctor.
Thank you so much for this study. And my heart goes to Spain. It was one of the hardest hit areas. So, but now things are getting better, so that's good. I just wanted to ask about the patients who actually, till now, after the COVID vaccine, they had menstrual irregularities that's not transient. It's for about a year now. Several patients still have menstrual irregularities. Some of them after the vaccine also developed some cysts and polyps, which were not there before. So I just wanted to take your opinion on this, or if you've seen any cases like this.
It may well could be. I mean, we don't really know the full picture, and it may well be because of the vaccines. But I mean, there can be many other reasons as well. So the first thing I would say is to try to rule out the most common reasons of cycles irregularities, of cysts appearing, than thinking of the vaccine itself. No? But you're right. I mean, we're still learning from this, and could it be from the vaccine? It could be. But I would first rule out other common causes. Mm-hmm. Thank you. Mm-hmm.
Any other questions or comments? Okay, fine. That was really comprehensive. For the sake of time, we're just running a bit late. So I'd like to thank you, for the nice presentation. And maybe we can take a short coffee break. And no coffee break even? Perfect. Okay. Then I'll...
Yeah, hand over to the two chairpersons. Yeah, they will do it. Yeah.
Yes, I'd like to pass the stage to you.
Yeah, they will do it now. Yeah, we will do in the break, but.
Is there the other one that helps?
Yeah, please. So for this, yeah, can you put it? Can you turn on the mic for Professor Fatemi?
So for the sake of time, if you want to grab a coffee, maybe you can go and come back, but we're going to continue the presentations because we are running a little bit late. So the ones who wants to have a coffee, you can grab it and come back. For the rest, we're going to continue with the presentations. How are you doing?
I'm fine, thank you. How is everything?
Thank you very much, Doctora. Pleasure having you with us. Please.
They will hide the screen. Yes, okay, thank you.
Doctora, you want to introduce the first presenter, Dr. Barris?
They told me you will present.
Okay, then I will present. Good, perfect. Yes. So sorry that we took away the coffee time. We're going to go ahead with the next presentation with my co-chair, Dr. Amal. The next speaker is known to you, Professor Baris Atta, who is working with us in Dubai as a scientific director. And I think he's going to speak about a very challenging topic. The topic is the recurrent implantation failure. This is an issue that we are dealing with very often, where patients have repetitively an embryo being transferred and they don't get pregnant. So I think Dr. Baris is going to give us some information on the repetitive implantation failures and how we have to proceed with those patients. Dr. Baris, please.
Dear chairpersons, dear colleagues, it's good that I don't have any videos in this presentation. I hope I'll be able to run it properly now. So, yeah, it is about recurrent implantation failure. I'd like to, mention a few things about it. One is I'll review the concept and its implications on our clinical practice as well as for research. Again, no conflict of interest. And it's not only my own opinion. We've recently authored a paper on this with my colleagues Erkan Calafat and Edgardo Somigliana. So the presentation is mainly constructed on this paper, which is available in Fertility and Sterility. So the concept, recurrent implantation failure is an abstract term. Abstract, I mean, we make it up. I mean, it's not something you can touch, it's not something you can image, it's not like appendicitis or it's not like a broken bone. It's a concept we've generated to guide us in clinical practice, okay? So it aims to define a person, a couple, let's say, who fails to achieve pregnancy while we would have reasonably assumed that they should already have had by now, okay? So now let's go one step back. It's same as infertility. Okay, so infertility, that's what we're trying to treat, is defined as failure to achieve a pregnancy over a reasonable time in the absence of an obvious reason. And that time is more or less arbitrarily defined as 12 months by the WHO. I mean, why 12? Why not 9? Why not 6? Why not 3? Or why don't we start investigating or treating couples if they present to our clinic with saying, we just tried last month, but it didn't happen. It's all about probability. The reason is, as human beings, we are not that efficient in producing healthy gametes. With healthy gametes, I mean, not all our sperm, not all our oocytes are haploid, so they don't lead to an euploid embryo. And it's a random event mostly, and even at young age, younger than 30, fecundability, which is the probability of achieving a live birth from a single menstrual cycle, which means from one oocyte and one sperm, is about 20-25%. So we wouldn't start worrying if a couple did not get pregnant with just 1 month's exposure. So what we chose to do, we wanted to give people some time, a reasonable time, reasonable attempt to achieve. Is there a time limit on this? Anyways, so what happens is it's a random event. So most people who don't get pregnant in 1, 2, 3 months, it's just by chance. Okay? So they don't have anything wrong. And if we start investigating them, we'll find nothing. So by allowing that time, we eliminate these people with no problems or little problems. Then at the end of that period, we have a concentrated population of people who really have other problems that make it difficult to get pregnant. And then investigation and treatment becomes worthwhile. It becomes a high-yield process. Okay? And recurrent implantation failure may follow the same logic. In IVF, again, we know that each and every embryo won't implant. I mean, if they did, it would be a wonderful world. Everyone would get pregnant with one treatment cycle if you had an embryo. I mean, since we know that each embryo won't implant, when should we start worrying about if any embryo will ever implant? So in this slide, you see 2 identical embryos. I think Ibrahim can correct me if I'm wrong. They can be graded as 4AAs, nicely expanded, thin trophoectoderm, good inner cell mass. What would you expect the chances of implantation would be for these embryos? Now, they look as good as they can. Any guesses? Sorry? Yeah. Let's see. The correct answer depends on whose embryo it is. It may look the same. Okay? I mean, one could belong to a woman who was 29, whereas the other could belong to another woman who is still young, but reproductively relatively older, let's say at the age of 42. These embryos would have very, very different probability of implantation just based on the fact that their risk of aneuploidy is different. Okay? So aneuploidy, those chromosomal copy number, say, abnormalities, is the leading reason, is the most common reason for implantation failure. And at the age of 29, for an untested blastocyst looking like this, that can be biopsied and tested, the probability of being euploid is 60%. And an euploid embryo, implantation rate is roughly about 60%, varies between 55 to 65 in literature, and mostly independent of age. So 60% probability of being euploid, 60% probability of implanting. Then the resultant implantation rate that you could expect is about 36%. On the other hand, similarly looking, nice, well-developed blastocysts, if it's coming from a 42-year-old woman, the probability of being euploid is optimistically 20%, even if that euploid embryo implants at the same rate, regardless of age, the resultant total implantation probability is 18%, half of the other lady. Similar looking embryo. So if with recurrent implantation failure, I'm trying to define a point where implantation is not happening despite my expectation, I need to adjust my expectation based on the anticipated implantation rate in an individualized manner. Okay. So where did I come up with these numbers? Why am I saying 29-year-old would have 60% chance of euploidy, whereas 42 would have 20%? Did I make them up? No, not really. These are different studies looking at embryo euploidy rates across female age. The first one was the one we did 10 years ago. There are more than 50,000 embryos here in this table. And what you can see in each age bracket, euploidy rates are almost similar. Okay? So there are slight variations, biological variations, or as different studies use different genetic platforms, there may be some variation, but more or less in the same age bracket, euploidy rates are stable. So we can use this information to inform our expectations for embryo implantation. And then we can define a threshold to define recurrent implantation failure. It's a simple mathematical formula. It's called the Bernoulli formula, but what you do is you put into the formula euploidy rate at a given female age when the embryo was generated, when the blastocyst was generated, if you're not already testing it. Then implantation rate of an euploid embryo, which is mostly age independent. Then if you're transferring untested blastocyst, aneuploids may implant in by chance of less than 1%, which will almost always lead to miscarriage anyways. But if you assume they may reach live birth by 1%, you can generate these tables. So this table is what it shows. On the x-axis, you see the total number of blastocysts transferred to a woman, either together or one by one, doesn't matter, the total number. On the y-axis, you see cumulative probability of implantation. And each color shows an age bracket. Okay. And what I like to highlight is, if you think in the same line as the definition of infertility, let's say, I would say, a couple, a woman should try, or let's put it this way: how many blastocysts should be transferred to reach an anticipated cumulative implantation rate of 85%, just like the definition of infertility? If you look at the numbers, even for young women, it's at least 4 blastocysts at the age of 35 or less. For 38 to 40, you see, to reach 80%, it's almost 9 or 10 blastocysts. And if you want to use a different line of thinking, a more stringent definition based on, say, statistics in a way, statistics I'm referring to hypothesis testing, in which we use commonly, we all see the p-values. What it shows is if you observe an association or an effect where in fact it's on a sample where in fact it doesn't exist really, okay? Or let's put it this way, we may if we observe an event, an association or an effect, whereas we never know if it really exists on the sample or in the general population. So we calculate the probability of just observing that association or effect just by chance. If that probability of being by chance is less than 5%, we assume it is significant, it's real. That's what is meant by p less than 0.05. Okay? So if you take the same approach here, then your threshold would be 95%. And then to reach that 95%, you would need 6 blastocysts to reach 95% under the age of 35, 10 blastocysts at 38 to 40, and if 41, 42, it's almost unrealistically high as 14. Okay. So this is based on observed euploidy rates in several studies over 50,000 embryos, and the published euploid blastocyst implantation rate. So it's an informed, say, evidence-based calculation. And let me show you another calculation. If you transfer proven euploid blastocysts with 3 or 4, depending on the implantation rate of euploid blastocyst, 95% of women eventually achieve implantation. So it's not only a simulation, actually. This observation has been corroborated by a paper, even though in a small sample, by Paul Pirtea and Richard Scott. So if a woman receives, if you exclude obvious factors at the beginning, if a woman receives 3 euploid blastocysts, eventually her chance of live birth is over 90%. Okay? Then what are the obvious factors that we need to exclude at the beginning? Okay? But before going to there, let's review the currently used definitions of recurrent implantation failure in the literature. So this is the Canadian guideline 2020. Not only guidelines, not only reviews, but they also covered studies that tested some interventions on supposedly recurrent implantation failure patients. See the definitions that have been used. The idea is always there, excluding poor prognosis patients, decreasing the random events to some extent, but see how small the number of embryos are required to label people as recurrent implantation failure. That means most of these women included in these studies most probably had failed implantation because of that random aneuploidy. So it creates a heterogeneous population, and the observations generated from those populations are probably, have little validity. So the literature is, I believe, severely distorted and reflects a lot of random findings. Okay, so coming back, why do I ever need such a abstract, say, term to lead my practice? It may have, implications for my diagnostic strategy, my therapeutic strategy, or my research. Okay, so from any term in practice should be functional. I mean, it should prompt you to do something different. So, as such, recurrent implantation failure, if I think the patient did not still have an implantation while I was expecting, based on these figures, that she would have achieved it by 80% probability or 90% probability, then I should consider, am I missing something in my diagnostic strategy? Should I do any other tests? Or should I change my treatment strategy? And let's see what those can be. Okay? This table looks complicated, but it's not really. It just summarizes the known reasons that may affect, the known etiology that may affect implantation process and decrease chance of implantation, except for aneuploidy. Aneuploidy is the most common reason anyways. And as you can see, they can be easily diagnosed by simple tools, like lifestyle factors, that Professor Fademi just showed, like obesity, smoking, excessive alcohol consumption, anatomic defects of uterus, congenital or acquired. Some of them have clear adverse effects, like submucous fibroids. Some of them, some clear effects, but interventions are controversial. But the point is, with simple tools like detailed proper history taking and a proper ultrasound examination and with a proper tubal patency testing, we can identify all those factors. If you want me to go back to that slide, we can identify all those factors before the first cycle. We don't need to wait until several embryos fail to implant, or, until after the couple fails 2, 3, 5 cycles. We can identify hydrosalpinges, we can identify adenomyosis, we can identify endometriosis, we can identify fibroids, we can identify the other risk factors. They should be handled before the first cycle anyways. So from a diagnostic standpoint, the only thing maybe we're not covering at the beginning is we may be missing, the rare balanced translocation in one of the prospective parents. Okay? So why don't we do a chromosome analysis or karyotyping to every single couple at the beginning? Because it will be a very low yield. You will find something abnormal in less than 1%. But if you use it as a second step, we may identify some of these couples which may give them an explanation. It's not something we can treat. And actually current NGS platforms may identify these translocations if they become unbalanced in the embryo, even if we have no prior knowledge of it. I mean, pragmatically it doesn't change much, but some of them may miss routine NGS, so may require specific probes. If you want, you can even do it at the beginning, but I mean, that is the only probably additional test that would be required if you decide that a woman, still did not have an implantation, proper implantation and live birth, why you would expect her to have done so 80, 90% of, with chance. The other thing, it's even more controversial. Even if you were sure that there was no hydrosalpinges at the beginning, treatment sometimes takes time, years. There might be another unnoticed infection, maybe a recent tubal blockage that's not clearly seen on ultrasound. And if ultrasound, not ultrasound visible hydrosalpinges effect, implantation is controversial, but that may be another reason. So except for these two, I can't think of any other tests from a strictly evidence-based standpoint. Forget about experimental things, that would be prompted by recurrent implantation failure. So from an assessment standpoint, it's not a really very relevant entity. Secondly, what can we change in treatment? Okay? Actually, when a transfer fails, the couple always has an expectation like, we would change something in treatment, right? So it's logical. Like, I mean, it's, say, why would you expect something different if you do everything the same? But I mean, we're never doing everything the same. Even if the stimulation looks same, it's a whole different set of oocytes. It's a whole different set of sperm. So it's totally different, okay? And then, what can we change? I mean, if we're doing stimulation and lab procedures correctly in the first place. If you think the other reasons of implantation failure or other factors that affect implantation, I mentioned a few of them, which observational studies suggest an adverse effect. A great example I like is intramural fibroids that are not distorting endometrial cavity. So proper prospective studies suggest even those fibroids decrease the chance of implantation significantly and increase the risk of miscarriage significantly. What we don't know if doing surgery and removing that fibroid restores these figures. Okay? So we may have our own opinions, but there's no proper randomized clinical trial. And I don't think it will be ever conducted soon because everybody has different fibroids, different numbers, different locations. But anyways, so it's a gray area. And you, your physician, and the couple may be reluctant to remove the fibroids before the first treatment cycles, because it's not only costly, it carries the risks of surgery, it carries risks of scarring, etc. Then she would have to undergo C-section. So they may be reluctant at the beginning, but if implantation still doesn't happen, if they don't achieve a live birth, after a certain number of blastocyst transfers, where you would expect, if the only problem was aneuploidy, they would have been pregnant by 80 or 90% chance now, then those risks of surgery or that controversial intervention may become justifiable. You can apply the same to adenomyosis. Say, if the patient has failed a reasonable number of cycles, even under hormonal suppression and frozen embryo transfers, then maybe the controversial surgical management of adenomyosis become justifiable. Okay? So that is how this concept may be used in clinical decision making from a treatment aspect. For research, I'll just say one slide, show one slide to mention one thing. Research is what? So research is making an observation in a sample, then making generalizations about the rest of, similar people. So there are two risks. One is having a false positive result. False positive means, whereas there's no such association or there's no such effectiveness, we may think it exists just by chance observation in our sample, or there's the risk of false negativity. While there's a real association, we may be unable to demonstrate it in our sample. So how does our definition of recurrent implantation failure affect these? So I'll give you two examples. The false negativity risk, let's say, obviously embryo euploidy and embryonic factor is very important, but there may be women, not everybody gets pregnant or achieves a live birth, even if you transfer maybe 15 embryos. There may be women who have some molecular defects in their endometrium. So these people are rare, since most women eventually deliver. Okay? But if I design an endometrial assay to identify these women, and then if I recruit 100 patients who are presenting for their first IVF, since it's very rare, I will maybe have not a single person with this defect in that population. So I won't be able to find that patient. I won't be able to show that. It will be false negativity if it existed in nature. But if, let's say, I recruit people after 2 failed cycles, these people are more likely to be there, but they will be most likely in my sample if I exclude almost everyone who would just fail because of aneuploidy. So if I use that stringent definition, exclude people who would get 95% of the time pregnant, then in that remaining small population, I'm more likely to find other problems. And if I dilute that study population with using these arbitrary definitions, then my research is most likely will yield false negative findings. And now false positivity. False positivity is, as I said, if the probability of observing an association or effect just by chance is less than 5%, by convention we call it real. Okay? So that is false positivity, technically. So using the incorrect definitions for just one paper may not increase the risk of false positivity, but there's not only one paper. There are a lot of papers looking at so many different interventions about this, with these different definitions of recurrent implantation failure. So just by chance, out of 100 studies, you would expect, 5 false positive associations or effective treatments. And then these are really the most dangerous ones for the patient, because then people read them and start using them all around the world. It affects actually hundreds, if not thousands of couples. Okay? And the problem, so this is I think my second from the last slide, the problem is not limited to this, it also has a psychological effect. Labeling people with a vague, abstract term, diagnosis like, oh, you have recurrent implantation failure. I mean, it really has a very negative connotation.
Could you finalize, Dr. Baris, please, because time is up and we are running behind.
Sure, last slide. They may be disencouraged from further treatment, whereas they would have reasonable chance if they continued. So it's a reason for dropout. Or even if they don't drop out, they'll start seeking for other non-scientific stuff, which may not be only not useful, but may be also harmful, and it will consume their time, money, and morale. So we should start doing everything correctly and completely at the beginning, which is possible, and then we should really keep our hopes up and the couple's hopes up with proper explanation, so they can keep trying for a reasonable number of times and until they will most likely reach live birth. And thank you.
Thank you very much, Dr. Baris. Really very interesting presentation. I think the key message, what I took out of your presentation is that one of the biggest predictors of a live birth is the genetics of the embryo. And I think this is something that we have to understand. The genetics of the embryo is the most important thing. I don't know, Doctora, if you want to add anything?
Yeah, of course, because I think the aim of the couples when they come with the infertility, they want a healthy baby by the end of the day. So the genetic is the most important. Thank you very much,
Yes,
Dr. Paris.
Until I did these calculations, I wasn't that a big fan of PGTA, but now seeing those numbers, especially over 37, 38, you can never inform the couple and you can't convince them why they fail. So I think it's really useful. Thank you.
Thank you. Good evening, ladies and gentlemen. Now we are going to invite Dr. Ibrahim Khatib. He is going to talk about not all PGTA is the same, critical steps determining accuracy and success. Dr. Khatib is a director of IVF Lab, senior embryologist, ART Fertility Clinics. Dr. Ibrahim has completed his bachelor in genetics engineering and biotechnology. He is also having a master's degree in health management, MBA in data science, and master in IVF biotechnology and human-based research. He has done his thesis on time-lapse monitoring system and pre-implantation embryology development, kinetics. Dr. Ibrahim has more than 10 years of experience in the field of embryology and was the part of the team that started the first ART fertility clinics in the Middle East. Welcome to the stage, Dr. Ibrahim.
Thank you very much, Doctor. Good evening, ladies and gentlemen. Of course, this topic is recently a very controversial topic. It's actually presented as a debate in almost every big Congress. I'm not sure if it will be that exciting at 9 p.m. on a Saturday, but I'll do my best. So eventually what we want to conclude at the end of this presentation, hopefully it is what are these critical steps that will help us in order to say yes, PGTA works, or conclusively say PGTA doesn't work. So, through this presentation, we're gonna give a brief definition about aneuploidy, the development of PGTA over the years, some evidence supporting and opposing PGTA, and finally these factors that can explain this contradiction. So let's start with what represents an IVF cycle. Of course, a successful IVF cycle requires collaborative effort between embryologists and physicians. That means that this includes, of course, the ovarian stimulation. This includes everything that is done in the lab, including the insemination, the culture, the biopsy, the freezing, and eventually the endometrial preparation. And most importantly, what we will focus on in this presentation, is embryo selection for transfer. So now with all the advancement that we have in the last 40 years in the field of reproductive medicine, still national live births did not exceed 30–40%, which shows that with all the knowledge that we think we have, there is still a lot to learn, and there is a lot of improvement that is required. One of these things is the embryo selection for transfer. So normally, in most of the IVF labs, morphology is the main criterion for transferring embryos, so we select based on morphology. Sometimes we can add morphokinetics, which is specific embryo divisions on specific times, or we can select embryos based on the chromosomal content. We do PGTA. Now, this is a real case from our lab. So we have embryo A and B, and clearly A is a much better morphology embryo than B. So conclusion is that this embryo was transferred without PGTA, no pregnancy. This embryo was tested, it came out euploid, transferred, and resulted in a live birth. Dr. Barish has already mentioned that morphology is not enough. So what is aneuploidy? Aneuploidy, in simple definition, it's a mistake during chromosomal segregation. So you have either an extra copy or a missing copy of chromosomes. Some facts about aneuploidy: it is the leading cause of mental retardation. It is a leading cause of pregnancy loss. It's a leading cause of obstetric complication, and so on. These are all facts, published data, health organizations in UK and in the States. So we can say, okay, then we will not transfer only medium quality embryo, we will take top quality, excellent quality. So in this paper, especially for patients over 38 years old, only 20% of excellent quality cleavage stage embryos on day 3 are actually euploid. And even if you extend the culture to blastocyst stage, only 50% are euploid. It means it's a 50-50 chance. And some of the facts that we also know that there is a direct correlation between the aneuploidy rate and age, especially maternal age. So with increased maternal age, there is increased chances of aneuploidy. And interestingly, in this study, they showed even at early stages of puberty, also there is higher incidence of chromosomal mistakes, which will result in aneuploid embryos. Miscarriage, Dr. Barish just mentioned that. 62% of miscarriages are due to aneuploidy after IVF cycles. And even if you look at spontaneous pregnancies, the miscarriage is due to 40% of these miscarriages are because of aneuploidy. So it's not only fertility that we are concerned about, but also the health and safety of the patient. With miscarriages comes along a lot of complications. So in this study, they looked into 70,000 women, of which they found that the women that they suffered from miscarriage, they are at higher risk of pelvic inflammatory diseases, urinary tract infection, ectopic pregnancy, and most importantly, subsequent infertility. It means even if the patient got a miscarriage after spontaneous pregnancy, this miscarriage can lead to this patient becoming infertile. So clearly, what we need to do is we need to do PGTA, identify these aneuploid embryos, put them on the side, and focus on the euploid embryos. Of course, it's not as easy as that, and we can see that through the development of PGTA over the last decade or two. So not only with the technology, so with the technology we moved from FESH to array next generation sequencing. With every time we improve the sensitivity, the accuracy, what we can test, the knowledge, even the outcomes. But also we had to improve also with the source of genetic material. So at the beginning, when we started doing PGTA, we were doing it for the polar body biopsy, which gave us information we didn't have before, but this information was limited to the maternal part. We had no information about the paternal contribution or any errors that happens after fertilization. In fact, in this RCT, for advanced maternal age patients, they showed that transferring embryos based on the results of polar body biopsy for these patients didn't improve outcomes. So obviously, we moved to another source of genetic material, which was the blastomeres at a cleavage stage. Now we had more information. We have information about the maternal and the paternal, and relatively some post-zygotic errors. But here we started to face a new challenge. Now, doing the biopsy at this stage affects the embryo development. And this was beautifully presented in the paper on the study of Richard Scott group, where they transferred for each patient 2 embryos, of which 1 embryo only was subject to biopsy. And they didn't look at the PGTA results, they just transferred. And they saw that there was significantly lower embryos implanted from the group that was subject to biopsy. It means it's harmful. Now, when they did the same design at the blastocyst stage, there was no difference between the 2 groups, which shows that blastocyst biopsy is safer than a cleavage stage biopsy. Of course, that is not enough for Dr. Fatemi, so we had to step in and do our own work. So we published in 2018 a comparison between cleavage stage biopsy and trophectoderm biopsy, and we saw a discordance rate of 18%. So 18% of the results were not matching. And in the following year, we even added one more comparison, which is the inner cell mass. And we found that we have discordance rate between the cleavage stage results and the inner cell mass by 23%, while we have only between the trophectoderm and the inner cell mass as a false positive, let's say, around 3 to 4%. And the evidence is compelling. So everybody agrees doing the biopsy at trophectoderm or a blastocyst stage, it's much better. Now, we took a brief about the definition of aneuploidy, why we need it, what are the factors that we need to focus on, and some kind of evidence, what is the best way. So we know doing biopsy on day 5, if we will do it. So now some of the evidence supporting PGTA, without going into details, this represents some of the many studies that they have shown that PGTA is helpful. So these are some studies, all are prospective, across different age population, and also infertility factors. All of them with the same outcome. PGTA is better. PGTA improves outcomes. Even the results of HFEA all showed across all age categories, again, better results with PGTA. So, till now, we know that if you do biopsy on day 5, you will get better outcome. However, despite all the studies that are supporting PGTA, we still also have many studies against PGTA. Not only not showing benefit, but also showing that transferring an abnormal embryo can result in a live birth. So this is a bit confusing, and we must meet in the middle because it's the contradiction is huge. Is transferring euploid embryo improves outcome versus transferring abnormal embryo resulted in live birth. So probably, in my opinion, the best study to guide us through the answer is this paper by the group of Santiago Monet. So what they did is very simple. Across different clinics, they did PGTA for the same patient population. And this patient population is donor patients. Donor patients are healthy, they are fertile, they have very low levels of aneuploidy. So they said, okay, let's measure in between these clinics. When they measured, they found a variation of 18 to 60%. It means that some of these clinics reported 3 times the aneuploidy rate than others for the same patient population. So the patients, there is no variable, it's not a variable, it's the same patient population. So what can explain this difference? 3 times the difference, that's a huge. The only explanation for that is something that we do in the clinic. It's something that happens after the patients enter our clinic. Which leads us to the factors that explain this contradiction. The first factor we're going to talk about is blastocyst biopsy. So luckily these videos worked, Dr. Barish. The first video here is a technique called pulling method. And this one is called the flicking method. It's very simple. We have cells hatching out after we make an opening. We will aspirate the same way. The only difference is how we will detach these cells. Here we're using laser. Here we will flick against the holding and we will sharply cut the piece. Eventually, these pieces will be sent to the lab and they will be biopsied. And these are some of many. Yeah, we assume that, okay, do biopsy, we did biopsy, we send the results, and that's it. And I don't think that there is any report, any genetic lab reporting or any embryology lab reporting their results, and they have a column called which biopsy technique did you use. We don't pay attention to these things. But in this study, they showed that simply the difference between these two methods you saw, it's not a huge, right? But the difference in outcome is huge. If you do pulling method, you have significantly higher mosaic results. Of course, mosaic results, it means less euploid. So you will not have the same outcome only by your choice of method of biopsy. Even if you go into more details about the method of biopsy, and you saw that there are some cells coming out, so we need to make an opening in the zona, even the day that you choose to do this biopsy is detrimental. So in this paper, they showed that if you do the opening on day 3, you have significantly lower ongoing and implantation rate. Look how detrimental is something extremely simple that we don't talk about, we don't mention. Normally it goes by without thinking. In addition to that, which is one of the important factors, the integrity of cells. Now, whatever material we're going to send the lab will be amplified, right? We don't pay a lot of attention about how was the quality of the cells. How did the piece look like? We don't know about these things. Even physicians, you receive the report only with the results. You have no clue about neither the biopsy method, nor do you have about the integrity of the cells. So in this paper, what they did, they divided the cells into 4 categories, where grade 1 is the best. You have more than 90% intact cells. And grade 4, you have less than 50% intact, okay? Look at the difference between euploid rate between grade 1 cells and the grade 4. Significantly lower euploid embryos if you have this type of cells. And even mosaic rate is significantly higher in this group. How we can explain that? Simply because the biopsy technique requires the use of laser, for example. Laser produces a lot of heat. This heat can cause necrosis for the cells. Necrosis produces the material that degrade the DNA. And then you send this material to the genetic lab, they will amplify whatever you have sent them. And then it will look like this embryo is missing a chromosome or part of a chromosome. And then you get a result that really doesn't represent the real status of the embryo. The third and very important factor is the number of cells. Now, in most of these studies, we say we biopsied 3 to 5 embryos. I mean, I cannot count any of these. These are all examples of biopsy cells. You cannot quantify them. This is something extremely subjective. And the effect of that, not necessarily on the result, but it will affect the outcome. So in this paper, they showed. Now, if you take a bigger piece, so more number of cells, you will have better or more reliable genetic or PGTA results. However, this will significantly decrease your implantation rate. So you also, as a physician or as a patient, you receive a report, this is a normal embryo, but we don't know how many cells we're taking. What if, when we did the biopsy, we took 15 cells? This will also decrease affect your outcome without us being able to clearly identify that. Last but not least, the IVF lab conditions and all patient-related factors. We're talking about a lot of very important culture conditions. For example, the temperature and the pH, they play an extremely important role in chromosomal segregation. And we said aneuploidy is a problem during the chromosomal segregation. So these factors are in the lab, and we can affect that. And this is how you explain the same patient population. They have 60% in one clinic and 18% in another clinic. So to summarize, PGTA is helpful. It's very good. You will reduce miscarriages. You will increase your ongoing pregnancy, healthy live birth. You avoid many abnormalities. It is operator dependent. We have a lot of variables involved in this procedure. And probably the best to explain let's say the dilemma is one of my favorite Formula One drivers, Senna, who was continuously faster than the competitors. When they asked them how come he's faster, they said it's his car. Until they joined his team. So I'm going to ask you the question, is it the car or the driver? Thank you very much.
Thank you very much, Dr. Khatib. It's so interesting. Any question? Yes, doctor.
Thank you, Ibrahim. Very interesting lecture, even though it's 9 p.m., but very nice.
Yes, thank you.
Do you think that then it will worth to centralize the analysis and the biopsy of the embryos in one single center with optimal results?
I think, doctor, this is it's variable. It's not something continuous. I mean, it's a continuous development of the procedure itself. Number one. Number two, culture conditions. For example, it's not like the first day we opened the lab, we did the calibration, and that's it. It's an ongoing process. I mean, of course, it will be better, at least if it goes well, we know why it goes bad. Also, it's easier to identify. It's a good way, since we're also a big organization, to think if we can centralize it. But I think that we can spread the knowledge, understanding that how important are these things will make us more self-critical, and I think we're all capable of doing it the proper way.
I think there was another question there. Hello. Yeah. Thank you, Dr. Ibrahim. Excellent lecture. My question is, what is your advice on transferring low mosaic embryos?
Excuse me?
Low mosaic. We get the report sometimes low mosaic. And what is your advice on that?
That's a very good and relevant question. Of course, due to time limitation and the topic, I didn't go into mosaicism. But the most important thing is we should not mix between biological mosaicism and technical mosaicism. You know, all the examples that I gave are actually, we're losing embryos for mosaicism because of technical errors. So if you get a low mosaic, and you see that in your lab you're getting a 15% low mosaic rate, it means that most likely, because it's 1 to 2% the biological mosaicism, so there is something happening. So, and there are evidence of studies transferring mosaic embryos, and you get a healthy live birth. But now we go to the same question: is it the car or the driver? I mean, that's why you need to be very critical on the total conditions before you decide whether you should attempt to transfer this mosaic embryo or not.
Can I ask you, what do you think? What is the prevalence of mosaicism in different centers, different clinics, different countries? Do you have any idea?
No, I don't have any idea, but the dilemma is that, I mean, we don't get many reports saying low mosaic, but the ones that we get, and let's say that's the only lone embryo to transfer, how do we convince the patient that it's okay to transfer?
So I'm going to give you some very interesting information. There is a presentation at ESHRE next week. I know it because it was shared with us before it was published. There is a study done by Mina Popovic from Barcelona. So she looked into the pattern of mosaicism in different continents, different countries, different labs. And it's very, very intriguing. The difference of mosaicism was between 2 and 28%. Between 2 and 28%, knowing that nature has a mosaicism of 1%. It means almost all the mosaicism, even the reports we receive, it's not a biological mosaicism, it is a technical mosaicism. And as Ibrahim mentioned, it is linked to the technicality. It is linked how we use the laser. It is linked how much of the cells you are burning. If the tip of the laser is 143 degrees, the cells undergo lysis. You kill the cells, you break down the DNA, and we create what we call technical mosaicism. And I think this is the killer of all the debates we currently have in the field of IVF with PGTA. Together with Dr. Baris, we wrote a letter to Human Reproduction, which is going to be published hopefully in the next few weeks, on a paper published by David Barat and Norbert Gleicher, stating that they have had hundreds of pregnancies after transferring abnormal embryos. The paper came out a few weeks ago. It's a very recent paper. And actually, it's misleading everyone. Because if you take a look at the data they have published, most of the pregnancies they had were mosaic embryos, technical mosaic embryos. I think out of more than 100 embryos they put back, there was only one really abnormal embryo. It means the margin of error is less than 1%, which is absolutely acceptable to me. So I think we have to put a question mark behind when we say mosaic and self-correction. It is not really self-correction. It is just a technical error. And I think it's a beautiful example Ibrahim used with Ayrton Senna. You have two same cars, but two different drivers. And one driver is significantly better with the same car. So at the end, it's not the car, it's maybe also a driver, it's a technical thing. And we need to fine-tune this technical aspect of it.
Just regarding the patient management, now in last year there was a nice paper by Emanuele Viotti. So they put a grading system. So first they showed that euploid should be first choice, and then the segmental mosaic with the percentages. So that will be a very nice for the physician and also for the patient as guidance what to do with this embryo, because it also depends on the chromosome.
So maybe last question you had.
Yes, hi, Ibrahim. Just technically, I wanted to know, I'm trying to optimize the outcome of haploid embryos. When do you do the hatching for the biopsied embryos?
At time of biopsy.
Okay. Not day 4?
Not day 3, not day 4. And in the paper I showed, when you do at day 3, you...
Yes, in day 3 it's less, definitely.
Yes, and you reduce also the chances of fully hatched embryos. You give the embryo a possibility to divide more. You can allocate where you want the laser, because if you do on day 3 or day 4, you don't know where is the location of the inner cell mass. But if you wait until day 5 or day 6, the day you will do the biopsy, you can control the inner cell mass. The shot of the laser will be extremely far.
So
you control everything.
So do you hatch and wait and just hatch or aspirate?
Hatch and do the biopsy.
Thank you.
Okay, thank you very much.
Dr. El Khatib, for this really beautiful and to-the-point presentation.
Thank you, Doctor.
And for the sake of time, I see everyone the battery is getting empty, so the lights are running. So we go to the last presentation, and I think it's a very interesting presentation by Dr. Raquel Del Gallego. I don't know if I'm pronouncing your name correctly, Raquel. So I have the pleasure to work with Raquel. She is one of the coordinators and assessors and a big contributor to our research that we currently are doing. She used to work in Spain as an embryologist, highly interested in research, very big contributor to our research, and her main topic of interest is actually AI, artificial intelligence. And she's going to give us an update on artificial intelligence and the future in ART. Raquel?
Thank you very much, Doctor, for the nice introduction. Okay, so today my talk is about artificial intelligence. And is artificial intelligence the future in ART? Okay, so like my ex-colleagues from Merck taught me, I'm going to start with the need of artificial intelligence. And it's a reality that we have years of data, and ART is a very complicated medicine that has tons and tons of data points. It starts from pre-stimulation, when we have the basic characteristics of the patients. Then we can move to stimulation when we have all of the protocols with different medications, different doses. Then we move to implantation, where we have the frozen, fresh embryo transfers and the medications and protocols. The clinical results, which we can vary them from implantation up to live birth. And then, of course, the laboratory parameters, which is where I'm more interested in as an embryologist, where we can have tons, as you can see in this image, of different variables that embryologists have to take care to the detail inside the IVF lab, so that our embryos are cultured in the best way possible. Right now, there's a lot of new data sources as well. And for example, PGT has proven to be a safe enough technique, and even though it's very costly, it's giving a lot of information for the patients, and that's why we introduce it into our lab settings. But there's also many other new techniques coming into the picture, like all of the omics. Morphokinetics has been with us for many years, and as well other new parameters morphologically that every year in the conferences, ESHRE, ASRM, we have a new morphological parameter being described. So all of these variables and parameters need to be analyzed somehow, and statistical power usually is not enough. So we need artificial intelligence to perform this massive analysis of this big data. So I'm going to explain the main applications where we could use our artificial intelligence in IVF. The first of all is expert systems or machine vision. And for this one, we could use it in classification and assessment of our stimulation protocols, deciding which protocol to use, maybe in the quality of our gametes, checking what's the fertilization outcome in the pronuclei and polar bodies, checking developmental events, if we have 2 cells, 3 cells, 4 cells, etc. Our quality in the blastocyst to classify if they are AA, BB, etc. And the trophectoderm, of course. And it's not showing here, but it was also ploidy. Then as well, we have another one that is machine learning, and if we go into more complicated version of its deep learning, and we could use it for prediction. We could use it for our success rates, for our prediction if the embryo is going to develop into a blastocyst, for our outcome or pregnancy rates, for embryo ranking and selection to assist embryologists, for ploidy again, and for statistical models for all of the kinds of studies and many projects that maybe the lab or the clinic has. Then as well, we have another one, which is robotics. Robotics, it could help us in automation in the techniques inside the lab. For example, how to align an oocyte for ICSI. There are new techniques that are helping us, and it's predicting that if you put the polar body in a certain place, it will be less detrimental to perform the ICSI to our oocytes. Or even assisted hatching. Where would you do the assisted hatching in the zona pellucida so that we harm the least possible the embryo? Then as well, if we can go into imagination, it could help us a lot in the workflow of the clinic because it can help us with the EMRs and the normal planning. And of course, these two are not that, they are not helping us nowadays in the IVF because natural language processing and speech recognition are not nowadays used, but maybe in the future, I don't know, it could help us in the call centers, or it could help us, the doctors, in the consultations to transcribe everything spoken into the EMRs. So this is one of the first papers I wrote and introduced me into the computer vision of AI, and it's actually a really nice paper, totally recommended if you want to enter this world, because it's very clear and very specific, and it's explaining in a very general way, because it's cell biology, not even for IVF, how can vision, machine vision help us? And of course, if you can see here, what it says is that the computer vision-based image analysis is resting on 3 main pillars, which are automation, because it's doing it automatically, completeness of an image, because it really looks into the full picture, and access to invisible data that maybe as humans we cannot see. However, on the other side, human perception is based on a very strong pillar called experience. And we as embryologists and those ones having a lot of years of experience can tell you by association with all of the embryos they've seen in their lives if an embryo is going to be good or bad. So it resulted in these 2 paradigms, which is when is human vision outperforming computers? It's nearly impossible to train a computer with all of the images we see throughout our lives. So in the end, this intuition that an embryologist has, it's very important in the lab. And on the other side, the integrator paradigm, which is the computer vision outperforming the human, it's helping us standardize this bias that can happen maybe between all of the embryologists in the lab, depending on their experience. And also, it helps us looking into way more number of parameters and avoids the human error, which even the best embryologist can have a bad day. So the ideal of this artificial intelligence, which will be having the AI to help us visualize, extract, and process this information, and then having an embryologist or a clinician making the last decision and interpretation of these results. So where are the benefits and opportunities, and where are the challenges nowadays? Of course, benefits and opportunities, as I explained, it would be to standardize assessment, to increase objectivity and reproducibility across different clinics. For example, our group is a big group. We have clinics in India, here in the UAE and in Oman. Maybe it would be a way of standardizing all of the clinics, increasing accuracy and precision of the predictions, and of course, hopefully and ideally, reducing the time to live birth, as well as a target goal for single embryo transfer to avoid multiple pregnancies, and it will help us to save time and improve our workflow, and of course finding new parameters. However, on the other side, and I'm going to state some of the challenges that we have in the main papers published on AI right now, but we were having a scientific discussion the other day in the clinic, and every time there's a new technique or a new way of saying things like this artificial intelligence, all of the papers published have a lot of flaws. But it's because they are very new that they are published. And it's good that they are published so that there's a scientific discussion that makes these models better and better. So the first challenge is going to be biased data. We need to train models with clean data sets, and sometimes they are very biased. So for example, this is a very good example. This is an unbalanced distribution of a data set. And in this model, and it's nothing about IVF, but two hospitals wanted to create a model to recognize if there was lung cancer in different scans. There were two main hospitals that worked in this project. The first hospital had a smaller sample or a smaller data set where they had 50% images of lung cancer positive, lung cancer negative. The other hospital had a way larger data set, and the amount of lung cancer in their images was way lower. It was maybe at 25%. So what they did, they trained the model, and the model learned that if you realize the images are very different. These images are way closer, are way brighter than those images are in a different angle, because maybe they use different techniques. And what the model realized was, okay, this group has more lung cancer. I will say that the brighter the image and the closest to the lungs, it's going to be lung cancer. And of course, this is not reality, and this is a different way, and we should be working on well-performed data sets before starting. And this comes into our field because this happened the same way. This is the strongest paper that has been published in AI in IVF. And as you can see here, this paper, everyone was very excited about it because the area under the curve was 0.93, which is increased like super high. However, when we go into deep analysis of the paper, if you realize the negative number of the sample size that they used for the training data set was 8,000 embryos, and the positive was 694. So when you go into deep, you realize that they trained the model with embryos that an embryologist will never even consider keeping in their lab because they were very fragmented or blocked on day 2, blocked on day 3. So they were saying, this is not going to be a live birth. Of course it's not. It will never get transferred even. So of course, the area under the curve was so high because it was really selecting blastocysts. And in the end, this is not what's meant from AI. We wanted to help us, not to state reality. Another challenge then, similar to what we saw, is image quality. So these images have to be very well processed by the team. And we have to segment the images to see areas of interest like our inner cell mass or our trophectoderm, zona pellucida, etc. Then we need to standardize the image characteristics, the texture, brightness, shape, and we really need to process this before we go into creating any model. And in fact, this publication from Esre last year was very interesting because it's using a time-lapse system that maybe we are all aware of. And if the embryo was perfectly located inside the well, the area under the curve of the AI system was quite high compared to the embryologist, maybe similar. However, if our blastocyst was a bit outside the well, the AI system area under the curve was dropping into levels way lower than the embryologist. So an embryologist will very easily recognize that this is a good blastocyst. However, the machine cannot. Another challenge is the outcome. What do we want to have as an outcome? Do we want to have an AI system that will help us to rank embryos in a standardized way? Do we want to have a prediction to live birth? And this is a very important point to decide, because maybe different clinics have different goals. And many papers have been attacked or criticized because of this. And maybe that clinic just wanted to have a standardized way. So it's perfectly viable as long as everyone knows what they are looking for. Then as well, we have here the clinical applicability out of it. And many artificial intelligence papers now are combining it with these new techniques called omics and so on, like, for example, proteomics, oxidative stress, even this very interesting one from last year, hyperspectral imaging. However, how much applicable is this into our lab settings? These techniques have to be done in external labs, maybe universities. We cannot do them in our labs up to nowadays, and they are very costly. However, like, for example, PGT, it worked, it's making a difference. So in the end, we started implementing it into our lab settings because it was making a good result. So who knows, maybe these new techniques are sometimes in our labs. And as well, a very big challenge and crucial when the model is done and finalized is calibrating it into our settings. Models can be created by different groups, companies, or universities, but are these models going to work to our settings? So this paper was published last year as well in ESHRE, and what they were saying is the calibration, how important it is. And if you see here the line, all those embryos falling under the line were overestimated. So they mean that the machine was saying, yes, they will give a pregnancy, and then they didn't. And the ones falling up were underestimated. So they were saying, no, they will not give a pregnancy, and they did give. So when they brought this model into a different clinical settings with a different IVF lab, they could see that for ages younger and middle ages, they were actually underestimating. However, when the age of the women were above 40, they were overestimating. So they calibrated the model according to age and according to clinical practice, and they saw that the lines of prediction started falling into the real predicted probability. So this is very important to calibrate models before making any conclusion if it's working or not. And I just wanted to make this slide on failure analysis, which is how do we know that the model, where is the model failing? Or how do we know if it's not working for us? And there's a very big legend on artificial intelligence that we don't know what the system is doing, and it's all a black box. But this is a lie. Like, we can really open the box and we can see where is the AI looking into the image, which areas he thinks it's better. And we can also see what are the different connections and the parameters that it's finding more important. So we should trust the models, but of course, we need to really know how was the model trained, what was the training data set. And as usually it's company built and so on, they keep it in a very low-key, secret, and we don't really know how were the models trained. So this is a bit of a flaw out of it. So as a conclusion, can we implement AI models into our lab settings? We need to understand how our lab conditions differ from the ones that they train the model with. And of course, this sometimes we are never going to know because they want to keep a secret, companies, but we really need to understand what's our patient characteristics to really check if it's going to work. Second, if we are going to use image, we need to really standardize this image, and we really need to work with a group of data analysts or image analysts to standardize this. Then as well, patient demographics and criteria, and we saw with Dr. Fatemi's presentation how much of a difference these make, and maybe patients from here don't work with a model created somewhere else in the world. We need to start validating the models, and we've seen in the past years a lot of new models created, but none of them were validated. Sometimes not even in their own clinic. No one has created a good RCT to really validate a model and see if it's working or not. But of course, this needs time, and maybe it will come someday. We need to calibrate the model according to our clinic data and to our patient characteristics and lab settings, very important. And of course, in the end, let's not forget about all of the parameters that can affect this outcome or prediction. A big part is the endometrium, and no one is taking care into putting endometrium in any model, and maybe even other characteristics of the stimulation or other characteristics in the process that we are not taking into account. So we should have a real model that covers everything in a more holistic approach, and let's see if it's really working. So thank you very much.
Thank you very much, Dr. Raquel, for this interesting lecture. Although it was the last, but it was also very interesting. So if there is any questions, please.
So do you think AI can, in future, the AI can replace the human intelligence?
No, 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 at all. And this is a very wide asked question, because it can help us and it can assist, but we will always need human intervention in the end and human decision in the end. Because of course, if the image is out of place, the embryo is out of place, or you know about something, or your intuition tells you this embryo is not going to be good, maybe the AI thinks a cell is what we know, it's a fragmentation, and it always needs the supervision of an embryologist. It will only help us and assist us in our workflow, but I don't think it will fully replace us at all.
Because so many research which has been taken place in 2018, 2019, 20, if you see the article which was published, basically they have given more advantage for the embryologist. Okay, it is good for the embryologist in comparison to the doctor physicians.
Yes.
So this I just want to know from you. Yeah?
I don't think so, no, no.
So not good for embryologists. Eh?
Not embryologists, not clinicians. I don't think we will always have the last word.
Everybody has to
So,
work on the same track.
Thank you.
Welcome.
Hi, Raquel. Yes, hi, Raquel.
Hello.
Would it replace, like in embryo selection, would it replace invasive techniques, maybe PGTA?
Oh, like we wished. We wished it could replace invasive techniques that our embryos were in the best way possible, that we didn't touch them and they were there. But of course, this is a dream that will take time and a lot of work. Yeah. And yes, it's like morphokinetics. It was also promising this, and in the end, it's not that easy. And it's taken a lot of research behind it. Different characteristics work for different clinics. So yes. It's as well like PGT from the secretum. Like these things, we are working towards it, but we cannot know.
Thank you.
Thank you. My question may not be directly related to IVF, but perhaps for genetic medicine.
Mm-hmm.
We know that the AI is using an algorithm, and for IVF, perhaps a universal algorithm will work. But say, for example, in genetics medicine, a universal algorithm may not work. Do you see any foreseeable future where the companies would allow that the algorithm will learn a regional, for example, a base for the data so that it produces more specific and personalized results?
Yes, definitely. And these algorithms keep learning on the way as well. And every time we are learning more, we can put it in, we can put all of this data into the algorithms. And in fact, I know that also genetic labs are starting to use AI into the way we, because of course, all of these PGT, they make these graphs of how the chromosomes are abnormal, and I know that many genetic labs are already doing this image recognition automatically with AI. So yes, it could also be applied there. Of course, as I said, as life goes on and we discover new things, new parameters, new everything, this should be applied into the models. But it's possible because they keep learning. So yes, it's a possibility there as well in genetics.
No more questions? Thank you very much. Thank you for the attendance. It was really a very fruitful meeting. We enjoyed a lot. Thank you, everybody. Thanks for all the speakers, for all the organizers. And I think there is a dinner after this. So you are most welcome, everybody.
Yes. I would also like to thank you all staying so long. Thank Merck, thank the Emirati Society of Obstetrics and Gynecology, all the speakers, all the chairpersons staying so long, asking all these interesting questions. As you have seen, many questions to be answered, and I hope that we can conduct further studies in order to answer these questions. And I think now it's time for dinner. Have a nice evening and enjoy your dinner. Thank you very much.
Thank you, Professor Fatemi. Just two quick notes. For the CME certification, please scan the QR code, yes, or on the agenda. There is a small evaluation form, and then you will receive your certification by email. For the dinner will be served at Brasserie restaurant. Our team outside will guide you through to the restaurant. Thank you so much and have a nice evening.